Good morning and welcome to the 18th meeting of the Citizens' Participation and Public Petitions Committee in 2025. Apologies for us being slightly late. We will be joined this morning by a galaxy of our parliamentary colleagues and talent from all different parties who will be joining us at different points during the course of this morning. And as always, I hope that time will permit to allow those who wish to contribute to our proceedings to have the opportunity so to do. Our first item is always the rather technical one of agreeing that we'll hear the evidence that we have considered this morning in private in items 4 and 5. And our committee colleagues content with that proposal? Agreed. We are. That brings us to item 2, which is the consideration of continued petitions. And the first of those is an extraordinarily important petition in which the committee has engaged and also undertaken a site visit on stopping the proposed centralisation of specialist neonatal units in NHS Scotland. This petition is lodged by Lynn McRitchie, who we were very pleased to meet in Wishaw, and the petition calls on the Scottish Parliament to urge the Scottish Government to stop the planned downgrading of established and high-performing specialist neonatal intensive care services across NHS Scotland from a level 3 to a level 2, and to commission an independent review of this decision in light of contradictory expert opinions on centralising services. Now, at our last consideration of the petition, the committee agreed to take evidence from the British Association of Perinatal Medicine, Best Start Perinatal Subgroup, and the Minister for Public Health and Women's Health, and we'll be hearing from the Minister at a subsequent meeting. But at today's meeting, we will take evidence from the British Association of Perinatal Medicine and then from Best Start Perinatal Subgroup. And as I said, we'll hear from the Minister at the next meeting. I'm pleased to welcome, and he's joining us online this morning. All your graphics have been reversed, sir. We're seeing everything behind you the wrong way round. But nonetheless, for those of us who can puzzle over that that'll be a distraction for those people who are following it. Proceedings difficult to work out what it all says. But we welcome Dr. Stephen Wardle, who's the President of the British Association of Perinatal Medicine. Good morning to you. And we also have our colleagues Claire Adamson and Monica Lennon, who have joined us this morning. And after we have got to the point of the committee having asked questions, hopefully, if there's time permitting, I would invite both of you to contribute to any question you might wish to put to the witness this morning. Dr. Wardle, I wonder if there's anything you would like to say by way of a kind of introduction before we move to questions. Or are you happy
just in terms of introducing myself? You've already said that I'm a consultant neonatologist. I'm the president of the British Association of Perinatal Medicine. The British Association of Perinatal Medicine is a professional organisation which represents perinatal professionals, doctors, nurses, allied health professionals, psychologists, pharmacists who work in neonatal services.
Okay, thank you very much. I mean, obviously, this is quite an emotive subject. We can all understand that, and our job is not to ignore that, but to approach it in as professional and, if possible, dispassionate a manner as we can, in order to ensure that both the aims of the petition are given a proper opportunity to be discussed, but also that Parliament and the government, Scottish Government, ultimately come to the right decision. So I'm interested, what are the types of local and national factors and constraints that the British Association of Perinatal Medicine would expect to be taken into account when implementing its framework's recommendations, and whether you are confident that these have been adequately taken into account in the proposals that have emerged in Scotland?
Yes. So in terms of the organisation of neonatal networks, there's some evidence around centralisation of services and the fact that this improves outcomes. We know that the smallest and sickest babies, when cared for in larger, more centralised neonatal services, have better outcomes. And in my written evidence, I've documented some of the evidence behind that and the references involved. And I think all of these references and this information and the framework that was produced on behalf of the British Association of Perinatal Medicine summarised all of this information and was taken into consideration in the Best Start review. So centralisation of neonatal services helps to improve outcomes. That means smallest and sickest babies cared for in larger neonatal units where all of the right resources, resources in terms of people, expertise, equipment, and the wherewithal to be able to deal with the smallest and sickest babies. That means that babies of 27 weeks and lower are all cared for in neonatal intensive care units rather than local neonatal units or special care units. Do I need to describe the difference between neonatal intensive care units and local neonatal units?
It might be helpful for the record just to do so briefly. I mean, the committee have gone through this previously, but I don't think it would be unhelpful.
Yeah. So in general, neonatal care is in neonatal units is the level of care that individual babies receive is divided and given a particular level of acuity, but individual neonatal units also given a level of care that they provide. The highest level of care, the most complex, the largest units are neonatal intensive care units. These are the tertiary units that care for babies across a wider region that look after the smallest and sickest babies. Local neonatal units tend to be smaller units at more local hospitals that care for babies that are born early, but not the smallest and sickest babies. So in general, babies from 28 weeks and above. And then special care baby units tend to be a slightly smaller service that provides care for babies at higher gestations who don't receive any intensive care. In local neonatal units, short-term intensive care can be provided, but babies that need long-term intensive care are cared for solely at neonatal intensive care units. BAPM and services have defined levels of dependency and the amount of activity that is required to be designated as a neonatal intensive care unit or a local neonatal unit. And those ensure that the throughput for the larger neonatal intensive care units is sufficient in order to be able to meet the criteria that we know is helpful in improving outcomes. So as you'll be aware, there are levels of the numbers of babies that need to be looked after in these sorts of units, and there are the number of intensive care days provided. There are minimum levels set, and those are set at a level which we know is helpful in improving outcomes.
Okay. No, that's helpful. Thank you. Now we'll come there. A lot of these questions, although we've got a pattern to them, cut across one another and are relevant at various points. Obviously, we're going to discuss why it was we went from 8 units to a recommended reduction of between 3 and 5 to just the 3. But when we were in Wishaw, I mean, the question I want to ask is, how does the framework aim to maximise the experience of babies and parents alongside maximising clinical outcomes and cost effectiveness? The human aspect, for example, this is an award-winning facility in Wishaw that we were visiting, highly experienced staff, at a geographical point that is accessible for everybody who is in the south of Scotland, in the knowledge that 1 or 2 of the larger units that already exist are turning away people because they don't have capacity, and the prospect, therefore, that somebody from Lanarkshire could end up in Aberdeen. And we spoke to a father who had what I would say was an awful choice to make, he said, if Wishaw hadn't existed, because following the birth, his wife was left in a life-threatening situation, and so he had to make a decision. He would have had to make a decision whether he would have had to stay with his wife, whose life was at risk in wherever, and his baby, who might potentially now have been in Aberdeen. And the human dynamic and all of that seem to be very much at risk, whereas there is an award-winning facility in Wishaw. We visited it. The quality of care seemed outstanding. And to us as lay people visiting politicians, it seemed difficult to square this circle.
No, I understand all of those issues. I think it's really difficult to be able to provide local services that are as specialised as they need to be in order to be able to care for the smallest and sickest babies. As I've said, the optimal way of doing that is by ensuring that care is centralised and that units are large enough to be able to care for enough babies to maintain expertise. That can be difficult, and movement of mothers and babies as a result of centralising care is inevitable. It's really important to try to avoid the movement of babies as much as possible. Ideally, sufficient capacity should be provided in all of the units who are providing the intensive care. And as part of a review and designation of services, it's really important that the larger units, the neonatal intensive care units that are going to be unable to take all of the activity, do have sufficient capacity, and that means staff and space to be able to care for those babies. If all of those things are provided, it should be possible to transfer mothers antenatally before birth when a preterm is expected, and that should avoid mothers and babies being sick. It may mean that care is provided slightly further away from home. Some families, that means that the capacity has to be in the right places so that those journeys and that transport is minimised as much as possible. Part of neonatal care, the intensive care, is the intensive care at the beginning when babies are very, very sick and need lots of expert intensive therapies and treatments. Later on in their care, many babies can be transferred back to their local units, and it's the system that seems to work well when networks are well organised. If the right capacity is in the right places, it should be possible to anticipate when women are going to deliver prematurely, in most instances, ensure that the smallest and sickest babies are born in the right place where intensive care can be provided on site so that the baby doesn't need to be transferred. And then when those babies have progressed and done well and are ready to be able to be transferred back to their more local units, then that transfer can happen. You also mentioned local expertise and excellence of some units. It's really important that expertise is maintained. It's difficult in some units where they're providing a higher level of care, particularly if it's seen as downgrading the care that they're providing to move to a lower level. These changes, though, aren't about individuals. It's not about which individuals can provide the best care. It's making sure that the right people are in the right place to provide the right care for the right babies, and that those are done in large enough centres.
But it's not always. Sorry, I was going to say it's not always the case that the outcome is a happy one.
No,
and we are in the scenario I was identifying. Equally, of the possibility that a baby had been transferred, say, from Wishaw to Aberdeen, when in the worst case scenario, it might not be possible for the parent who is also concerned about his wife to be present in the event things didn't work out well. I mean, these are very considerable potential distances that we're talking about here. And I just wonder, when you say that the adequate capacity will be available in these larger units, I don't know that parliamentary colleagues are terribly reassured that that has been the pattern when other services have been centralised.
Okay. Well, I think that's down to how these services are commissioned, isn't it? And I think that if the resources are available, it should be possible to commission sufficient space and capacity in the right places. In terms of transfers, I agree that transferring women and babies very long distances isn't ideal, and that's why the right capacity has to be in the right places. Unfortunately, outcomes aren't always good, and provisions need to be in place to be able to deal with those situations.
Okay, thank you. I know Davy Russell would like to just come in on this point. Davy?
Yes, you basically said there that, well, travelling isn't good for especially the baby. However, you referred to the appropriate capacity being an alternative unit. So, but basically the nearest unit to Wishaw is Glasgow, right? But Glasgow is at or near capacity. So basically there would need to be some capital investment put in there to increase the capacity before there was any decision taken about closing Wishaw. Would that be right? Or would that be sensible?
I don't know the particular circumstances in Wishaw and Glasgow in terms of what's required in order to open sufficient capacity or what the right capacity would need to be. Sometimes capacity just means more nurses or the right number of nurses to look after a particular number of babies or a level of activity on a particular neonatal unit. And I'm not aware of what the exact circumstances are in Glasgow that limit capacity at the moment. It could just be that more nurses are required. It might be some capital investments for a larger space. I'm not sure about those issues, but ideally, yes, all those things should be provided in order to enable capacity to be transferred.
Thank you, Convener. Good morning, Dr. Wardle. Does the proposed location of Scottish units raise any concerns about the disproportionate rate of transfers from areas of high deprivation?
High deprivation. I mean, high deprivation can lead to a higher incidence of prematurity and sometimes poorer outcomes. In what respect do you ask about deprivation? Do you mean that transferring might be more difficult in those circumstances, or?
In areas of deprivation, usually health is poor, so you'll probably find more cases of premature babies being born and needing these specialist units.
Yes, that's possible, and that's often the case. Again, it goes back to capacity being in the right places. As long as there's sufficient capacity so that care can be transferred when it's required. And again, coming back to the distances, the distances need to be reasonable. I think the review has recommended 3 eventually neonatal intensive care units. And as you pointed out, Glasgow would be the closest to Wishaw. I don't know enough about the local circumstances, but as long as there's sufficient capacity provided, it should be possible to manage.
On that point of capacity, Central Belt in Scotland has the greatest capacity of our population, and Lanarkshire and Wishaw, the whole area, has a high density of population. Would it not make sense to put the units where the highest density of population is, rather than having them go to Aberdeen or Dundee, areas like that?
I don't think I can answer those questions. I think all of those issues were reviewed in the options appraisal, but I or my organisation didn't take part in that review. So we don't have a specific view on that, but the principles that we used were those that BAPM recommends in terms of centralisation of care to improve outcomes.
David, do you want to follow up on any questions here?
A couple. The review mentioned that between 3 and 5 operational units, obviously Scotland's population is 5 million. Where, using your expertise, would you think that the right amount of units would be? Would it be 3 or would it be 5 or would it be 4?
That's a good question. I think that geography certainly would need to come into it, but the size of the population and the number of deliveries that occur in Scotland is similar to the size of a neonatal network in England. There are 10 neonatal networks in England. Typically, each of those neonatal networks has 2 neonatal intensive care units. Some of them just have 1, some of them have 3 or 4, but in general, around about 2 neonatal intensive care units is the number that's required for that size of population. Obviously, geography has to come into it as well.
What would you think would be a reasonable distance for mother and baby to travel?
What's reasonable? I mean, mothers and babies do get moved around considerable distances sometimes. Ideally, when care is provided within networks, the distance is minimised. Some of the networks in England are large and require transfer of mums and babies over significant distances. But I don't think there's a set distance or time limit that's set on transfer. I think the key thing is making sure that the capacity is in the right place and that the transfers are minimised, particularly transfers of babies. If mums need to be transferred rather than babies. But I don't think there are, certainly we don't make recommendations about distances. But by organising care within networks, that helps to minimise those very long distance transfers.
How easy is it to identify mothers who may be prone to giving birth prematurely? Is there any methodology you would use or pre-work you would do so that the mother's in the right place, probably closer to the right time?
Yes, yeah, there is. And lots of work goes into this. And this is a question really for an obstetrician, but there are tools that can be used to predict which mums are going to deliver early. Sometimes there are clinical factors which make that more obvious. Things like multiple births. Women who've had a previous preterm birth are at higher risk of delivering early. Some women with problems with their cervix, for example, can be at risk of delivering early. So on most occasions, the obstetrician can predict when women are likely to deliver early. Some women just go into labour early, and that can't be predicted. But as long as they can be transferred early enough in the process, that can be done in a safe and timely way. Unfortunately, there are some women who go quickly into labour prematurely, unpredictably. And in those circumstances, that's when the baby needs to be transferred after birth. But as I've said, that's less than ideal, and it's what we try to avoid. And that's the purpose of organising care in networks and trying to make sure that mums are transferred rather than babies.
Thank you.
Maurice Golden, do you want to follow up on any of these points just here?
Yeah, I think that would be really helpful, Convener. I mean, I think everyone agrees there's clearly already a degree of centralisation by the very nature of, you know, we're starting at 8 specialist units. But I think the concern is the rationale behind how we ensure not just the best clinical outcomes, but the best patient outcomes. So, you know, for example, I'm interested in cases where, because of closures, families might have to live apart and the impact that might have. So, for example, last month, the Courier reported on the case of Lois Cathro, who had triplets born at 32 weeks, all under £4 in Ninewells Hospital in Dundee, and they received excellent care. However, she said, had the unit not been there, we could have faced an unimaginable situation. So I'm interested, would it be conceivable that parents and families may have to make round trips of hundreds of miles between hospitals to see their babies, and what impact might that have not just on their clinical care but on their overall well-being and potentially even future health and mental health outcomes?
Yes, I think travel for parents is a really big issue when care is centralised. I think it's really important that, as well as the capacity to look after babies, that we provide facilities for parents as well. That means accommodation for those parents who've travelled long distances. It means help with those travel costs. It means help with things like parking and food whilst their baby's receiving intensive care. So I think all of those things need to be considered and hopefully provided where possible to make that journey for those parents easier and more bearable, because it's a considerable emotional and stressful experience having a premature baby and dealing with that situation. Caring for babies as close to home as possible, so trying to avoid very long distance transfers and transferring babies back to their local unit when that's possible based on their care. And I think if all of those principles are considered, then hopefully we can optimise the experience that families have and try to avoid very high costs for families, particularly those from deprived backgrounds, and hopefully avoid the stress and difficulties of having their babies being cared for a long distance from their home.
And thanks for that answer, but I suppose that's the nub of the point. It appears as if the arbitrary methodology behind the closures down to 3 is really setting mothers and very sick babies almost up to fail by building in that level of travel from the outset. So there's huge swathes of Scotland, parts of the most deprived parts of Scotland, that are losing services if these closures were to go ahead. And I just wondered whether that, in your opinion, needs to be reconsidered.
I don't think it needs to be reconsidered on that basis, but I think optimising outcomes is clearly the reasons for centralising care in this way and making these recommendations. But providing appropriate care for parents and families is really key in all of that. The difficulty is to continue providing care in lots of smaller units to try to avoid transport ultimately means fewer babies will survive and more poorer outcomes. And the resources required to support the level of intensive care that's needed in a large number of smaller units, would be high, trying to provide the right staffing levels in all of those places. Not that centralising care is about saving costs. It's not. It's about improving outcomes. But to try to provide care in that many units would be difficult in order to difficult in terms of providing the right staff at the right level with the right expertise.
Okay, but I'm not a clinician, but clearly there's a degree of centralisation already. So we've got 8, and perhaps the number going forward should be 5 or 6. And understand the Princess Royal's already in Glasgow, so I would presume the effect on parents wouldn't be so severe in that case. But it seems to me down to 3 boils down to finances, and that is deeply concerning. I wonder if you could assuage those concerns in any way.
I don't think I don't think it is about. Our recommendations are not around finances; they're around improving outcomes. And if we want the best outcomes for our babies and families, then centralised care provides that. So I don't think it's around costs. The costs clearly, need to be borne in mind, and within a system where resources are not endless, then clearly those things need to be taken into consideration. But our recommendations are around improving clinical outcomes.
Okay.
Thank you.
Fergus, you wanted to come in?
Yes, thanks, Convener. I mean, I do understand the basic point that Dr. Wardle is making quite fairly, that his views are driven by the desire to get the best outcomes. I mean, that's very understandable, and where there are very low birth weight babies, obviously that's something that is extremely worrying for everybody. But I do understand, although I wasn't in attendance myself, that during the visit that committee members made to Wishaw, it was put to committee members that the process of centralisation in England was perhaps going to be revisited. Is that a false rumour, or is there substance to that?
No, there were no plans to revisit centralisation in England. In fact, in some networks, there's ongoing review of the care that's provided and the designation of units, but there are no plans to revisit that type of centralisation. I think that type of providing care in operational delivery networks with centralisation of care for the smallest and sickest babies continues and is planned to continue. There are reviews in some networks, excuse me, to look at where that care should be provided in the same way that care is being looked at in Scotland, and the designation of individual units. But no plans to revise that.
Well, thanks for clarifying that. In your in the witness statement, you state, I think, that the recommendation in Scotland should move from a model of 3 to 5 units in the short term, progressing to 3 units within 5 years. I just kind of wonder, as I represent the seat of Inverness and Nairn, which is kind of in the centre of the Highlands, but the Highlands is an area roughly the size of Belgium, and the journey time from, for example, Wick to Aberdeen is 4 hours 41 minutes by car, 204 miles. I'm absolutely no brief against my colleagues and friends representing the Wishaw area, but the journey time from Wishaw to Glasgow is 30 minutes and the distance is 20 miles. So just putting it in perspective, the geography of Scotland, once one leaves the central belt, is of very sparse populations by and large, spread over enormous areas. I mean, if it is your clinical judgment that there should be a move to 5 and then to 3, what would you say to those who say that if there is nothing in the Highlands, that the nearest place is Aberdeen, that really does mean that those people who are living in the more rural parts of the Highlands, and you could make the same case for the south of Scotland and other rural parts, the north east and Argyll and the islands in particular, that they're kind of second-class citizens when it comes to neonatal care. I mean, what would you say to that? And could I specifically ask if, in the course of your deliberations, you gave consideration to sort of geographical justice, if I can put it, make it into a rather short, if somewhat crude phrase. But I think, Dr. Wardle, you can see what I'm driving at here. That there is very, very strong feelings in places like Wick and Elgin that maternity service should be retained there, and indeed campaigns have been going on for many, many years there and then.
Yeah, I can see the difficulty, and I've already said that geography needs to be taken into consideration when making these decisions. Scotland is unique and is different from many other areas of the UK. But it's very difficult to provide this sort of very specialised care in remote areas. and it's hard, it's very difficult to provide it in very small units on multiple locations. Similar sorts of situations exist in other countries. Australia is a good example where transfers need to happen over very long distances, and there are some very rural locations. The key thing, I think, from a neonatal point of view is ensuring that transport services are good enough. And I know that in Scotland, there's a well-developed transport system, the ScotStar system. It's really important that the resources and the wherewithal are available to be able to transfer babies when necessary over large distances from these very rural locations. So I think having transport properly resourced and equipped and available is key in terms of providing the care to those sort of women and babies.
Well, that. Sorry. Just a final thought, indeed. Well, I guess in Canada they have flying doctors precisely because of the same issue, and in Australia you have the same thing in the outback, and our outback is the Highlands. So what you're advocating is that health services in remote areas must have on-call contracts either with helicopters or planes in order to transport, where necessary, the mother and baby to a centre of excellence to receive the specialist care that your advice is essential. Is that right? That must be part of the service.
That must be part of the service.
No ifs, no buts.
Yes, agreed. In order to be able to provide care for those women and babies, they need to have the appropriate transfer facilities available.
Thank you. I'd like to invite our colleagues joining us this morning to see if there's anything they might want to put by way of a question. I'll come to Claire Adamson first.
Thank you very much for the opportunity, Convener. Good morning, Dr Wardle. If I could just recap on some of the things that you did say earlier, that ICU care in neonatal units will still continue in Wishaw and in the other hospitals that currently provide that service at the moment.
So I think the proposal is that Wishaw would become a local neonatal unit. Local neonatal units will provide intensive care on a short-term basis. So that means up to 48 hours. They will still look after babies of 28 weeks and above. So still considerably premature, but not the very smallest, sickest babies of 27 weeks and below.
Yeah. And in terms of the issue of the facilities, at the moment Wishaw doesn't have a facility for neonatal surgery. Glasgow does. How important is that, and how often is that required for the smallest and sickest babies?
It's really important to try to co-locate paediatric surgical care together with neonatal intensive care where possible. That doesn't mean that every single neonatal intensive care unit needs to have surgical care available, but a proportion of smallest and sickest babies will require surgical input. Couldn't give you an exact figure off the top of my head. Something like 10 to 15% would be a guess of babies might require some sort of surgery in the neonatal period. Extremely preterm babies. So where possible, it's really important to provide paediatric surgical care and other paediatric specialists on the same site when that's possible. It is possible to provide neonatal intensive care without surgical care on site, but when problems that require surgical input arise, then sometimes those babies might need to be transferred. And that might be a time when those babies are sick and unstable. So it's always better to try to avoid that situation when possible.
And if I could turn to the example that Mr Golden gave, and I want to pay a tribute to all the parents who have given evidence and everyone who speaks so highly of the care that they've had. units. But the example he gave was triplets at 32 weeks. He said £4. I'm sorry, I don't have the capacity to translate that into kilograms. But would those babies have fitted that criteria of smallest and sickest, given that they were 32 weeks?
Babies at 32 weeks gestation would be able to be cared for in a local neonatal unit. And the type of care that those babies are likely to receive is likely to be short-term intensive care. It's unlikely that babies that are born at 32 weeks would need more than 48 hours of intensive care.
And a final question, do you have any statistics about the centralised, what difference the centralisation has made to the outcomes and survival rate in England?
I don't have data specifically to answer that question, just to look at survival rates before centralisation and survival rates after centralisation. However, we know that outcomes are improving, survival rates are improving over time. And we know from the data which I've referenced in my written statement that when people have looked back at the care provided in larger units and compared it to smaller units, that there are clear differences in outcomes. It would be interesting, I think, to look specifically at the question you asked, but it's a little bit tricky to define a set time period when changes have occurred and when you might look at those sorts of changes. What we do know in England is that babies are, on more occasions now, being delivered in the right place following centralisation. So the smallest and sickest babies, the ones that we know are most at risk and that are most likely to have a poor outcome, and whose outcome we know is improved by being cared for in a centralised unit. More of those babies are now being cared for in centralised units.
Thank you. Thank you.
And Monica Lennon, would you care to ask a couple of questions?
Yeah, thank you, Convener, and thank you to the committee for all your work, and especially the visit to University Hospital Wishaw, NICU. Thank you, Dr Wardle, for your written evidence and oral evidence today. Just to put that into some context, are you able to just explain for the committee's benefit if you or your executive committee members have visited the site at Wishaw or Glasgow, or indeed the other units that we're discussing today?
No, we haven't. We haven't taken any part in the review that's taken place in Scotland. I'm giving evidence based on our framework and our evidence that we produced as an organisation, but we haven't taken any part in any of the decisions or the reviews that have happened in Scotland.
Thank you for clarifying that. The reason why I ask is, you've made a number of important points about what should be in place for babies and families across Scotland in terms of the right resources, the right transport, the right capacity. And you've cited evidence that's informed your position around centralisation. But the evidence that we have as MSPs, especially those of us who represent communities in Lanarkshire, is that we don't have enough resources, we don't have the right transport, and we don't have the right capacity. Would you accept and acknowledge that the unit that we have in Wishaw today is not simply a local unit? It's serving a huge region of Scotland, as the convener set out at the beginning, and already is serving as an overflow capacity site for NHS Greater Glasgow and Clyde, because the reality is that already Glasgow can't cope. And by the Scottish Government's own admission, the modelling that's been done so far, and may already be out of date, is that at least dozens of babies from Lanarkshire will have to go to Aberdeen, which is a considerable distance by ambulance. And as you said yourself, that travel is not ideal, and that would put babies at risk. So if you could address those points, that would be most helpful.
again, I go back to the right resources being in place in order to provide the right capacity in the right places. I don't think I'm in a position to comment on local circumstances, just the principles underlying them.
Okay. Well, thank you. That's really helpful. I think, Convener, that just reinforces my position all along that these decisions need to be informed by people who work in the local services, who've used the local services, and they need to have a seat at the table. Just because you are the British Association of Perinatal Medicine, Dr Wardle, and clearly have the best interests of patients and your members at heart, do you think it's regrettable that no one from NHS Lanarkshire had a seat at the table and was able to ask questions and form the decision when we've had clearly clinicians from Glasgow and elsewhere on there? Do you think, in terms of having robust decision-making, that there should have been representation from NHS Lanarkshire?
I mean, I don't think I can comment on how the review was organised and who was invited. I think it's important to have stakeholder review from all parties, but I don't think it's our position to comment on who was invited.
Okay. Thank you. Yeah, thank you, Convener.
Thank you. Dr Wardle, thank you very much. I hope none of that seemed unduly testy or anything. I really it's strayed into various areas. Obviously, it's quite an emotive subject, but I'm very grateful for the range of evidence you've been able to supply us with this morning, all of which will help inform the committee as we review this petition and our recommendations or otherwise as we go forward. So I'm very grateful to you. If there's anything else you'd like to add, or are you content with everything that you've been able to contribute at this point?
No, I'm happy with everything I've contributed, and thank you for the opportunity.
And again, and your graphics came round the right way eventually, so we can now see them without having to have a scribe. So thank you very much for joining us this morning, and I'll just suspend briefly while we change witnesses. Thank you. Welcome back, and we continue our evidence session in respect of the petition 2099 on stopping the proposed centralisation of specialist neonatal units in NHS Scotland. And in the second evidence session this morning, delighted to welcome to Holyrood Jim Crombie, who's the co-chair of the perinatal subgroup, and Dr Andrew Murray, who is the co-chair of the perinatal subgroup. Is it two co-chairs, or are there other co-chairs not with us?
Yes, there were more co-chairs, but it's us two representing.
Right. Okay. So we've got two of the posse of co-chairs with us this morning. I'm very grateful to you both for joining us. Is there anything you'd like to say by way of an opening remark, or are you happy for us just to move to questions?
Happy.
But, fine. Thank you very much. Could you give us some clarity over the intention of the Best Start report with regards to the final number of units? Because obviously we saw that we had 8 and there was a recommendation to move to between 3 and 5, and that the recommendation ended up at 3. And I suppose what the committee is concerned to know is whether there is scope to move beyond that 3 towards the 5 that was within the range of parameters that were discussed. Dr Murray.
Thanks. The intention was very much to acknowledge that the way Scotland services were currently set up was not in line with the best evidence, and I think you've just heard really clearly from your last witness exactly the level of evidence now that meant that we needed to look to change and reconfigure the services. And it came very much down to the fact that there has to be that critical level of expertise and activity within the units to ensure that we achieve the best outcomes, including mortality. So more babies will survive. We will get better outcomes if the critical mass of activity and expertise in those units can be achieved. And as you've heard, that's 100 births per year of those particularly low-weight babies. And so we were aware, and the Best Start programme was aware, and set out in its recommendations that we were not in a position where we could essentially guarantee and assure ourselves that we were delivering the best services because of the more disparate nature of the way these units had been established previously. So therefore the recommendation was that we move to that evidence-based approach, which underpinned that reconfiguration with that you've heard the evidence from the British Association of Perinatal Medicine, that figure of 100 of these very low-weight births, and also respiratory ICU days. We should use those to really see our services through those lenses, again, to ensure that we can then deliver the outcomes that the babies and the patients deserved.
And the question of whether it was 3, 4 or 5?
The question whether it was 3, 4, 5, again, it was going to be driven by that option appraisal and the data that we had. Again, your last witness was very clear that the activity, the number of these births within Scotland, that probably would only reach the threshold for 2 such units in a network in England. So we knew that we were going to need to use that data. But that was the data that was going to drive the final decision making. And as you know, that data is clear that we're not able to justify, if we're really committed to those improved outcomes and that reduced mortality, we're not able to justify any more than 3 units. The move from 5 units, there has to be a transitional period where, and you've just heard again very eloquently, the need for resources to be put in place, the need for the pathways to be put in place, everything that needs to support a successful implementation. We were touching on inequalities earlier, the EQIA work that now needs to be put in place to underpin that and make sure we get it right. That transitional period is what I envisaged as one of the co-chairs, that 3 to 5 unit period, but moving very clearly towards that vision of ultimately there being 3 units.
And just to touch on something Monica Lennon asked, because this obviously came up quite a bit when we were on our visit, the review group included representatives from Glasgow, Edinburgh and Aberdeen. And coincidentally, the 3 centres are going to be in Glasgow, Edinburgh and Aberdeen. South Lanarkshire weren't represented. I understand actually they were invited, but they took the view that because there was a material interest, they understood to mean that it might be prejudicial for them to take part, not realising that in fact it probably was prejudicial for them not to take part potentially as a consequence. But was that therefore, notwithstanding their view of how it might be interpreted, not something that could have been challenged to ensure that the review group was more representative of all of Scotland rather than just those centres of excellence that ultimately benefited from the outcome of the review?
I think that's a really good point. It's perhaps important to note that the review kicked off in 2018, and in the period 2018 to 2024, the Chief Executive of NHS Lanarkshire was involved, as was the Head of Midwifery, Lynn Clyde, both from NHS Lanarkshire. There's a need to ensure that the approach to something as important as this is taken forward in a way that allows individuals to contribute and focus and use the data. And we felt, I think, certainly as we moved the programme forward, that we had both clinical expertise and we had representatives from key clinical groups that were informing the science of this and informing the decisions and the subsequent options appraisal, so that the outcome was predicated on evidence and on improving outcomes. And I think I heard a question around finance driven. There were no finance representatives on the subgroup. The criteria for options appraisal did not have a financial criteria. It was based on clinical outcomes, clinical co-locations, and the availability of the clinical expertise at the volumes that Dr. Wardle has already briefed.
Okay, thank you. David Russell, do you want to pursue that point?
Yeah. I've got a few things here. Do you accept the potential for bias or conflict of interest in relation to the membership of the subgroup and expert group?
I don't. These were a range of extremely experienced individuals. They were there often in national roles because of their expertise. And we required that, and there was actually, I think there was people from out with Scotland as well, so that there was a clear attempt to get the right people with the right expertise to inform the decision making, and I think that there wouldn't be any, from my perspective. The conversations, as you heard Jim lay out, the options appraisal were all about objective criteria. Co-location of services, you either have that, you don't. It was going through a process of trying to build up that very objective picture and subsequently the decision making was also reviewed by one of the Deputy Chief Medical Officers as well to I guess to do a kind of integrity check of that decision making. So no, I think the integrity of the members of the group shouldn't be impugned. I also think that some of the members on that group were from health boards who, again, are not part of that final three. There was individuals from Tayside and possibly others if we review the whole list. So I think we had, and certainly as the chair, what I got a sense of, having been involved in a few national pieces of work now, was the absolute commitment by these clinicians to achieve that best outcome for their patients. And they were trying to do that in as objective and as transparent a way as possible.
Bearing in mind, Dr. Wardle mentioned that there's some evidence to back this reduction from 8 down to 3. He didn't say there was a lot of evidence. He says there was some. And he referred to the fact he'd never visited the sites. It was more like a desktop exercise. Going forward, do you not think it should probably have been done maybe in stages to see how it's working rather than the dive from 8 to 3?
Yeah, I think that's a really good point. And we tried, I guess, to consider that. And there was the opportunity, obviously, with the pandemic. And just prior to the pandemic, we had set up early implementer sites so that we could test some of the thinking around this. And that was creating that wider network. So Crosshouse and Ayrshire linking to the QE, and I think it was Fife linking into Lothian colleagues, so that we could try and I guess problem solve what issues might arise. In terms of Dr. Wardle's statement around the evidence, I think the evidence is really, really compelling. There's multinational studies from lots of very high thought of centres, really always coming back to this point that unless you have enough experience to be managing 100 of these of the sickest babies, you're not going to get the same outcomes. The mortality rate is going to be higher in these areas. So if that point wasn't coming across clearly in the previous evidence, certainly from our perspective as co-chairs, we've got a pretty copious evidence list that comes to that repeated conclusion, which is why we needed to pursue this piece of work.
What efforts were made to communicate to the stakeholders the membership of the subgroup and the reasons for their appointment?
That question again?
What efforts were made to communicate to the stakeholders the membership of the subgroup and the reasons for their appointment, basically families, everybody else?
Yeah, I guess we ensured as part of the programme, the neonatal subgroup, that we had representatives of, if you like, patients' voice. So we had the Chief Executive of Bliss as part of our programme, and she informed a lot of our communication processes. The membership and the remit were published, they were available widely. and we reported to the Best Start Programme Board that again had further representation out with Glasgow and Lothian. So there was a series of communications and transparency of content and process as we move forward. And Bliss were immensely helpful in supporting that communication out to the wider users, etc.
Thank you.
So, excuse me, except that on our visit to Wishaw, I have to say everybody we spoke to was scathing of the contribution of Bliss.
I'm not aware of that.
I can't really comment on their view of that, I'm afraid.
Well, insofar as they felt that they were completely distant and that there was no direct engagement whatsoever, and that what they got was simply a pro forma kind of advancement of their view without that actually being one that was the subject of any direct engagement whatsoever.
Yeah, sorry, I couldn't comment on that individual relationship that Bliss had with that centre. So we would need to see if we've got anything that would correspond to that. But we'd be happy to do that if that's an important point.
Sorry, David Russell interrupted.
No, that's fine. That's fine.
Okay. Fergus, were you indicating you'd like to come in on something at that point?
Yes, thanks. The witnesses have said that careful consideration, as one would expect, was given in arriving at the recommendations, the key recommendations, that there should be three over a period of time, and those are Glasgow, Edinburgh and Aberdeen. What consideration was given to choosing Inverness?
The evaluation looked at all of the 8 units, and the criteria, the option appraisal criteria, referenced, I think what's important, referenced key clinical elements of the provision. So throughput, co-located expertise. Dr. Wardle referenced paediatric surgery, the co-location of that expertise on the same site, a number of other clear criteria, and they were matched. Each of the units were matched against that. And it was clear as we came out of the options appraisal that there were 3 units that were scoring. There was a margin between those 3 and the other units. So from a clinical evidence point of view and a clinical data point of view, it was clear those were the 3 units.
I can understand that with the specialisms that are present in Glasgow and Edinburgh. I should say my partner's a very senior anaesthetist of nearly 40 years practice in the NHS. One can understand that with the specialist services, it makes sense that Glasgow and Edinburgh would be 2 of the choices. I mean, I think most people would agree with that, wherever they represent in Scotland. But the decision about Aberdeen, and I'm nothing against Aberdeen, I mean, so one country, but I understand that Aberdeen is not expected to meet the recommended threshold of 100 very low birth weight admissions per year, and therefore Aberdeen is by some way behind Glasgow and Edinburgh. I mean, would it not have been possible to provide more specialist resource into Inverness in order to provide, if you like, a degree of geographical equity? And without downplaying Aberdeen, could there not be a case for 4? Given that, as I've just quoted to Dr. Wardle, the distance to travel from most places in the Highlands to Aberdeen is around about 3 to 5 hours on the islands a day. To Inverness, from Wick to Inverness, is about 2 hours 20 minutes. So, I mean, it's not great, but it's possible to travel to Inverness more readily. So I'm just looking at things. This is geographical, and I do appreciate clinical decisions, I guess, must trump everything else where there's a case of a baby that requires that specialist care. I understand that. But would it not be possible, Mr. Crombie, to have 4 centres, one of which would be Inverness, although that would require more resource to be placed in Inverness, more consultants, and more provision for emergency situations, if I could put it crudely like that?
It's a really complex question, and the ambition to have all services available to everyone as close to home as possible is an ambition. However, the evidence, the clinical evidence, I think is very clear. If you have units that are not delivering consistently a volume of care at this level, specialist care at this level, then the outcomes from those units will be less than the units that are providing. Now, you're correct, the Grampian unit does not deliver the 100. Our estimations of the actual activity around Grampian, and then the flow from Tayside would bring it to circa 80. But with the clinical network support and the geography, we considered there was a point where potentially there would be 2 units in Scotland, because the volume said, yeah, you could do 2 units in Scotland. But for that very reason, the geography, we considered we should be able to support a 3rd unit, and that unit would be in.
Just finally, I mean, did you look at demographic trends? And the point I'm making here is not perhaps immediately obvious, but it's obvious in the Highlands, which is this, that the population of Inverness is the fastest growing, I think, in Scotland, possibly the fastest growing city in Europe, and the population increasing. I don't know if it's fresh air or something in the water or something, but over the next 10, 20 years, the population is due to expand, I think, more rapidly than anywhere else in Scotland, not least because of renewable activity in the Inner Murray Firth. Various figures have been put on it, but I think around about 30,000 over the next 15 years. That will substantially increase the pressure on Rakemoor, which is falling apart at the seams. It needs to be replaced, there's no doubt about that. I mean, if we're thinking strategically about Scotland, these decisions need to be made on a long-term basis, do they not? And if it's a long-term basis, surely we can't just isolate the Highlands. And I think paragraph 56 in your report, covering risks and conclusions, and I was going to quote from it, but it'll take too long, did specifically say, oh, Aberdeen is fine because it means that it negates the problem of journeys travel for the north. Well, I'm very sorry. No, it doesn't. So I'm surprised to see that comment in your report, and I wonder whether you might want to rephrase that or recast that. But more important, I mean, is there not a case for looking again very, very carefully at the changing circumstances, demographics and otherwise in the Highlands, which really would, I think, offer a very strong case for providing 4 centres, not 3?
Yeah. We didn't look at those projected demographics, but what we did do was take the opportunity post-pandemic to re-evaluate some of our data from all the centres to see if we were starting to see any new trends that were emerging. And at that point, there wasn't anything that changed the decision-making. And I think also I think the information from the option appraisal and the scoring has been made available to colleagues. You'll see there is actually a significant difference between Grampian scores and an Inverness score. So it wasn't as if there was it was a close decision that we could potentially have looked at that 4-centre solution.
Well, that could be redressed. That could be redressed, though, because there's been a shrinkage of consultancies.
It was cut and dried.
Okay. I think I should actually say I don't think Inverness was one of the 8. Currently, but Maurice Golden, you were going to raise issues around this same area. I don't know if there's anything further you want to pursue on the back of what Fergus Ewing's just asked.
Yeah, I suppose it's around the cut-off point ultimately. I mean, clearly throughput was one of the criteria used, and I appreciate what you've said around Glasgow and Edinburgh, but, you know, the difference between Aberdeen and Queen Elizabeth, based on the scores, is 17. Difference between Aberdeen and Dundee is 29, and then it drops off a bit more. I just wondered, you know, the case for Dundee, for Wishaw as well, in terms of that wider package. So beyond clinical outputs, I mean, clearly in an ambulance you can get from Wishaw to Queen Elizabeth quickly, but if you're travelling from Lanarkshire or and indeed once you get down to the south of Scotland as a parent trying to visit your very sick child, then you can be stuck for hours around Glasgow, whether you go M74 or M8 around the city to get to Queen Elizabeth in Govan. And I just wondered how that was packaged into the overall findings.
I guess, as Dr. Wardle said, the premise is to create facilities that offer the sickest babies, the lowest weight babies, the best opportunity to survive and thrive. And that was central to our thinking. In terms of the implementation of these recommendations, that you described needs to be part of that process. Scottish Government set aside funds to create support to families as part of this programme, and that was augmented later in the programme to try and support that which you've identified, because there's no doubt as you centralise, you increase the distance people will have to travel. So I think there was recognition that the strategy was going to have an impact. It was going to certainly have an impact, but that that was outweighed by the absolute benefit to the sickest of babies surviving and thriving.
And if I could just add, so any compromise that we would have made on that critical mass, so there was a lot of discussion around the veracity of that evidence that I've just outlined. We did need that conversation to take place and a lot of assurance around how can it be such a round number? That seems convenient, doesn't it? So we did look at that statistically, and we had a whole range of experts who were able to contribute and explain. And the consistency of that evidence internationally, as I said, was really what meant that any deviation from us having that as our ambition, so that wider package as you're choosing to describe it, then the corollary of that is poorer outcomes for babies and an increased mortality rate. And that wasn't what we would be able to countenance as part of the group being charged really with driving up those standards and those outcomes.
Thank you for that. And just final question. I mean, the report is the first step around a new way of delivering this sort of care. But as part of that, it's predicated on having a support network in place in order that the rationale behind the report can be justified ultimately. And I think my concern is that support network may not be there. You know, after you have reported, then who is accountable for delivering the ultimate, recommendations in your report to make your rationale successful ultimately?
Yeah, I think that's a really, really important question. When we completed our option appraisal, we wanted to offer additional support to the areas that would be implementing. So we wanted our analysis of numbers of women that would be transferred to these units, because, as Dr. Wardle said, the ambition is to move the mum with the baby still in situ, so that is the safest transfer. So that was our focus. We procured external expertise to model the impact of our recommendations, so that it was clear and explicit what the flows would look like. I was then very clear that this was of such significance that there needed to be accountable officer level leadership in the implementation. And through Scottish Government, we required each of the regions involved to designate a lead chief executive, and that individual would oversee the implementation of our recommendations. And I was really clear that offered the best opportunity of this clinically imperative model of care to be delivered. And the accountability was clear in that structure, I think.
Thank you, panel.
Davy Russell.
Listening to Dr. Wardle, he had says that transportation is key to this, right? Whether it be air ambulances in the islands and highlands or just ambulances here. But we hear day in, day out, about waiting times for the ambulance. So have you budgeted and have you got enough ambulance to, if a patient's going from Wigtonshire to Glasgow or wherever, basically it takes a vehicle and a couple of people out the system, it could be a day, so that will, have you made arrangements to increase that bit of your business, or is it somebody else's problem?
Well, it's part of the implementation programme. Scottish Ambulance were a member of the neonatal intensive care unit and the specialist element of Scottish Ambulance ScotStar, which are these clinical experts. Someone mentioned a doctor getting on a plane and travelling. These are highly expert clinicians, consultants, who support the transport of these very, very sick babies. And they were fully involved in these discussions and were clear about the capabilities in play. Yeah,
but it's capacity issues I'm really talking about here, where, that right now You hear my inbox is full of people waiting X amount of hours for an ambulance, right? If you're taking somebody out of the system, then if you're taking somebody out of the system for a day in some cases, then that's going to be a bigger strain in capacity.
There's no doubt about that. The numbers, we have to pay attention to the numbers here, and the numbers which require that level of transportation and the level of specialist transportation, and that was part of our modelling. As part of the implementation, each of the regions will work with Scottish Ambulance Service, which, as you know, is a national board, to look at what the infrastructure requirements might be currently, and what augmentation they would need to be put in play.
Okay.
Thank you, Convener. Good morning to witnesses. How do you respond to criticism that the option appraisals exercise was waived towards surgery, which does not adequately reflect the needs of most preterm babies?
Thanks. Yeah, so co-location of surgery was within the criteria, as you rightly say, as also was co-location of other critical services. I think that was a question that I kind of heard Dr Wardle, I think, pick up on, and I'm not a neonatologist, and I think he was able to give us an estimate of the numbers of these very unfortunate babies who might come to require surgery. So it is important that that was a factor in there, but it was one of many clinical factors that were taken into account. But you heard about the risks of transfer for that surgery into a specialist centre, and therefore co-location was very desirable as part of the option appraisal.
I might just add to that, as my colleague said, the options appraisal was much wider than surgery. We looked at the co-location of paediatric medical specialties, including respiratory, gastroenterology, ophthalmology. We looked at cardiac, congenital, diaphragmatic hernia, abdominal. We looked at a whole bunch of criteria because I think, as Dr Wardle said, when you have the co-location of these experts on the campus, then the ability of that campus to support these vulnerable babies to survive and thrive is optimised. So it wasn't just a focus on surgery.
No further questions, Convener.
I found all the evidence we've been considering fascinating, and I just want to, for the sake of the petitioners, be pejoratively politically. Because what it seems to me is that there is an idealistic argument here based on the technical availability of services and the likelihood of the best survival prospects for children. And then there is the reality that politicians come across on behalf of our constituents every day, that this great transport network within the health service that's going to ferry these children from the south of Scotland up to Aberdeen at the click of a finger when the need arises is available when we have constituents waiting up to 18 or 24 hours for an ambulance to turn up to take them anywhere. Or whether the additional kind of consideration that, in fact, what's going to happen is that they'll simply go to Glasgow. But I was talking about the parent in a previous evidence session, you may have heard, who had a critically ill wife and was concerned that in his circumstance, would he have stayed with a critically ill wife, or would the child not have been in Glasgow but at the other end of the country? And in a sense, it seems to me that what the clinical directive has generated here is what they believe to be the outcome that would lead to the highest level of survival in the sickest babies. But it's dependent upon something which politicians in our experience have found doesn't always follow, which is the infrastructural support that is required behind it. And that at some point down the line, we will have constituents coming to us who have had an experience which will have been absolutely against everything you've identified as being the clinically designed outcome, because the practical reality was they didn't get the support that was necessary, and they feel that they lost a child in the worst circumstance because of it.
It's difficult to argue against that. The impact on individuals' families should be a component part of our thinking. There's no doubt about that.
Could I also add, you described the ambition as idealistic, but I think we heard from Dr Wardle that other countries have done this. England has done this successfully. I think he's saying that he caveated it obviously, but he thinks they're starting to see evidence about those improved outcomes. And so, although the reality, as we go through this difficult implementation process, I don't think there's any doubt about the devil being in the detail and trying to make sure that everything is aligned to support the reconfiguration. We talk about the reality and people experiencing the difficulties going through it, but actually our reality could be that we deliver that improved network and improved system with improved outcomes, which I think is what we all want.
Okay, thank you. Again, I'm going to invite my two parliamentary colleagues, if they would wish to just contribute a question. Claire Adamson.
Thank you. And it was around the ScotStar Specialist Transportation Unit. I understand that this is an ambulance only used for transferring the sickest babies, so they wouldn't be part of the other pressures on the general ambulance service. But what about a woman who has been transferred? Would they go on if the baby's still in situ? Would they go with ScotStar? How would they get to?
So my understanding is ScotStar is only for the transfer of the babies, but you know I'm happy to be corrected. It's staffed by anaesthetists, or colleague earlier mentioned, connection to anaesthetists.
So a parent wouldn't necessarily be on that transport with the baby at the time?
Again, I would need to double check because I should know more about this because our ScotStar experts were very clear. But yeah, I mean, it's primarily for the transfer in an intubated and safe environment of the baby. I think parents have to follow, but I'm not sure of the operational detail, I'm afraid. Obviously.
I suppose with this lower number of specialist centres, would the call upon that service not be considerably greater than is the current experience?
No, not necessarily, because the premise is that women are identified as being vulnerable in terms of premature birth, and the women are transferred to the unit for that prenatal point. So ScotStar wouldn't be involved in that process.
No, but I meant the ScotStar itself. I mean, at the moment there are 8 centres, but obviously if there were only 3, might not the call upon that resource to transfer people to just 3 that were further away be greater than is the current case when there are 8?
I don't think so. I think that you've heard the ambition is that we've got that early identification of the mothers so that they are in the right place for that delivery to take place. So, and that's one of the key principles to underpin all this. There'll be less movement, there'll be less emergency transfers taking place. And actually, with there being fewer centres, we might find that actually works more easily because of the established relationships that are there. But I'm speculating.
Thank you. Monica Lennon.
Thank you, Convener. I know that time is tight and I think there are still more questions and answers, but for now, I just want to get some clarification. Mr. Crombie, you said that when your group was making these decisions, there was a recognition that the strategy would have impacts, but these were outweighed by the clinical benefits. And Dr Murray, I heard you say that now the work will begin on undertaking the quality impact assessment. These issues have been looked at since 2018, and I'm hearing today that work is now beginning to look at the equality impact assessment. There's been some nods given to what the social and economic and financial impacts might be, as well as the clinical impacts and outcomes. So can you, for the benefit of parents who are sitting behind you today and people who will be listening and will read this official report and want to be assured that everything has been given due consideration, can you tell us what are the impacts and what evidence has been gathered to make sure that all the other issues around being more trauma-informed, trying to think about the health and well-being and life chance of the woman as well as the baby is also being given equal consideration?
Yeah, so I'm not sure when you said there's more questions than answers, so I'm happy to clarify anything I might not have answered to your satisfaction. The prime responsibility of this subgroup was to offer a view on optimal provision of specialist care for the sickest, the lowest weight babies in Scotland. Using evidence, clinical evidence and clinical expertise from the membership of the subgroup, we formed a view that the research and the clinical expertise were pointing us to higher volume units, so a smaller number, specialist units providing higher volume care, because in that there was evidence that says the care within these specialist centralised units will be optimised. That, we knew, meant a reduction of access to that specialist care from 8 units to 3. And therefore, we recognised there was going to be an impact on individuals and on families. And part of our implementation needs to look at things like, what about the finance hit, Scottish Government identified funds? What about accommodation? Well, we need to look at how we're going to provide accommodation in these areas. What about transport and access? We need to look at these things with Scottish Ambulance and with ScotsCar. So all of these issues were identified and are part of the ongoing process of implementation. There's no getting away from the fact that this will have an impact. But I strongly believe that the evidence that we heard, the evidence that we saw, the clinical opinion that we sought was explicitly clear to offer our sickest babies the best opportunity to survive and thrive. This was the model of care that should be in place in Scotland.
So I'm still not understanding the sort of status of the quality impact assessment.
So sorry, that was a comment I made. I stepped back as co-chair, and the status of the work, I guess it has now started to move into that implementation. So what I would need to seek from the current team supporting that work is a statement for you to get, try and encapsulate where we are against those requests that you've just made.
Apologies, I thought you were still currently the co-chair. How many co-chairs have there been?
There have been a few co-chairs.
Okay.
The pandemic got in the way. There was a protracted timescale. So I think there was probably 5 or 6 of us ultimately. All of us, to give you some assurance, were, I think we would regard ourselves as being at very senior level, and we were asked specifically by the chair of the Best Start Programme Board, who had detailed conversations with us about what the roles would entail.
Your clinical expertise is valued and appreciated, but we've had 5 or 6 co-chairs, people with national experience, people from outside of Scotland, but no one from Lanarkshire.
Well, I think I pointed out that Heather Knox, the Chief Exec from NHS Lanarkshire, was involved in the early part of the programme, and Lynn Clyde, who was Head of Midwifery in NHS Lanarkshire, was involved in the programme.
But they've not made decisions. And I think, as the convener said, they tried to do the right thing by not trying to prejudice decisions because they felt they had an interest as one of the units. But it looks like there's not been some consistency around other people's decisions. Sorry to interject,
but I try to give you some assurance that the options appraisal process is objective. It's either are these services there or are they not. So the difficulty, as you can appreciate, when there's representation from all parts of the country, is that there is lobbying occurs then that's not based on that evidence. And so we were trying to create a high quality, and it was our colleagues in NSS that supported us through this whole process. So this is approved national methodology for all sorts of service redesign, and to try and make that as objective as possible. And I think that's what we'd want to stand by.
On the
It's a conclusion of
Thank you. Yeah, just then on the Wishaw NICU, because we're hearing a lot today about the importance of high volume in order to maintain that level of specialty. Everyone that I speak to is under the impression that the unit at Wishaw is high volume. It's already struggling to cope with the demand. It already services demand from Glasgow and elsewhere. What is it that they're doing wrong just now? Because we're hearing about we need to have the right people, the right place, but they are award winning. They're serving a huge population in Scotland and doing it to a very high standard. What's broken about that? Because it seems to me that that works well. They need more capacity, but why would we want to downgrade that unit when it's already performing an excellent service to the people of Scotland?
So I disagree with some of your descriptions. No one was suggesting much of what you said there. They do provide a level of activity, there's no doubt about that. But we're looking at activity linked to the smallest, the lowest weight babies, and those that require the highest level of intervention, with the co-location of services that support that ongoing provision in that space of time post-birth.
They just don't have the co-location of the services, which would make this service more comprehensive and really try and achieve those better outcomes. I've no doubt that they're very skilled committee clinicians, as a resident of Lanarkshire myself.
Yeah. Convener, just an observation on that, because I know I have to hand back to you, but it sounds like if co-location was a factor, then that was weighted against Lanarkshire right from the beginning, because that was one of the criteria you mentioned. So it sounds like our local service had no chance with all these different co-chairs, and that's regrettable. Thank you.
The option appraisal is because that's what the evidence base that shows 100 of these deliveries achieves the better outcomes, and it's because of the co-location. So that had to feature in our option appraisal. That had to be the rationale for it.
I'm going to draw things to a conclusion there, but I want to thank you both very much for both the concise but also the informed evidence you've given. These are highly emotional and emotive issues, and at no time, of course, I hope you would get the impression the committee is anything other than respectful of your own clinical experience and that experience that you brought to any review. But in pursuing the aims of the petitioner, I often say we are at a magnificent advantage in this committee in that we are not following any party's political election manifesto. We are following the aims of a petition that has been lodged by people who are concerned, and our job is to take that argument as far as we possibly can. And so I'm very grateful to you both for the time you've given us this morning, and I'll suspend briefly before we move on to the next item on the agenda. Thank you. Welcome back. Thank you very much. Our colleague Maurice Golden has had to leave us to move amendments on another committee, so he's no longer with us. We are now moving on to the consideration of additional petitions. And as convener, it's very difficult to have to admit, but I think we've got something like 119 or so petitions still currently open, and hardly, or at least very few meetings of the committee left before Parliament dissolves in April next year, with the last sitting day of the Parliament on March the 26th. And so very much now the committee has to determine what we can do further with respect to open petitions, even while that might cause disappointment to petitioners in respect to petitions that we still think there is merit in and which may yet even be capable of being progressed. And it may very well be that some of these petitions will be best progressed by the tabling of a fresh petition at the commencement of the next session of Parliament in May of 2026. We are going to look at 4 petitions now, which were part of a thematic health care evidence session that we had with the Cabinet Secretary for Health, Neil Gray. And these are petitions 1723, essential tremor treatment in Scotland. Petition number 1871, the full review of mental health services. Petition 2017 to extend the period that specialist perinatal mental health support is made available beyond 1 year. And petition 2070 to stop same-day only GP appointments. That health-themed day looked at the themes of patient experience, diagnostic and treatment pathways, capacity, skills and training, sustainability of funding and health service infrastructure, and the post-COVID-19 impacts and response. And to a greater or lesser extent, we were able to explore these issues with the Cabinet Secretary and also to follow up some further matters in writing. This morning we are considering the petitions which sit under the patient experience theme, the first of those themes. The committee has explored the specific issues raised in the petitions by seeking written evidence from stakeholders and ministers. The thematic issues have also been explored in our recent oral evidence with the Cabinet Secretary. And during the thematic evidence session, we raised that a number of the petitions have highlighted a gap between policy strategies and how services are experienced. The Cabinet Secretary accepted there can be gaps between policy and delivery, indeed the very subject of the evidence session we've just held, and noted that there can be a variation in delivery between health boards for geographical or demographic reasons. We're joined this morning again by Monica Lennon in respect of one of these petitions. I'll invite her to say a few words after I've summarised the petition, and by our colleague Douglas Lumsden in respect of petition number 2017 on perinatal mental health support. Monica Lennon here in respect of the full review of mental health services. The first of those petitions, petition 1723, was essential tremor treatment in Scotland, was lodged by Mary Ramsey. It called the Scottish Parliament to urge the Scottish Government to raise awareness of essential tremor and to support the introduction and use of focused ultrasound scanner for treating people in Scotland who have this condition. And the Cabinet Secretary confirmed that the ultrasound service is being provided in Tayside. In the written follow-up, it's been confirmed that 47 patients have been treated between April 23 and April 25 in Dundee. No patients have now been referred to England for this treatment, and during oral evidence, the Cabinet Secretary stated that if it were found that a service had a level of demand that would merit expanded provision beyond one specialist service in Scotland, this is something the Scottish Government would consider. So considerable progress made in respect of that petition. Petition number 1871, a full review of mental health services, lodged by Karen McEwen, who I think we heard from at an earlier stage in this Parliament, on behalf of Shining Lights for Change. And it calls on the Scottish Parliament to urge the Scottish Government to carry out a full review of mental health services in Scotland, to include the referral process, crisis support, risk assessment, safe plans, integrated services working together, and the first response support and the support available to families affected by suicide. and we've pursued the issues raised by the petitioner. During oral evidence, the Cabinet Secretary highlighted the government's focus on preventing people from moving into a mental health crisis in the first place by looking at whole family support, addressing poverty and social factors to reduce the acute level of mental health need. The then Minister for Social Care, Mental Wellbeing and Sport, Mary Todd, also wrote to the committee in October October 24, in response to a range of concerns raised by the petitioner, including data on effectiveness and consistency, admittance to mental health acute beds, workforce wellbeing, training for the wider mental health and wellbeing workforce. And the petitioner has provided a written submission highlighting outstanding issues in relation to data collection and reiterates her call for review of mental health services. Are there any brief comments you would wish to add at this stage in the consideration of this petition, Monica Lanham?
Thank you, Convener. Yes, on petition P1871, lodged by my constituent Karen McKeown. I've been working with Karen for several years, including on the petition, and again pay tribute to her, and really grateful for the work that the committee has done. I think having that health theme scrutiny with the Cabinet Secretary is really good, because we want to look at things in a joined up way. Karen highlighted to the committee in her letter of the 18th of November where there has been some progress, because we can't sit here as MSPs to say everything is terrible all of the time. So like Karen, I agree and welcome that 80% of staff in Lanarkshire have now completed mental health carer aware training, and that's really good. But what we're seeing is still a crisis across Scotland. I would challenge the Cabinet Secretary's words that there is a focus on prevention. I think that is the intention, but the practice again is somewhat different. Just at the weekend, I was listening to the Scottish Police Federation talk about the huge demand on frontline police officers to provide a mental health crisis response. Not anything new, but it's getting worse. So given that constituents are telling us there's an over-reliance on the police, that more and more people are having to find money to pay for private treatment, even when they can't really afford to do that, and that we're seeing the NHS wanting to deliver prevention, early intervention, but is still bogged down with dealing with crisis. It feels like there's still more to be done here. I know we have another new minister, and I welcome Tom Arthur to his post, and I think it'd be really good to hear directly from Tom Arthur as the Minister for Social Care and Mental Wellbeing about what fresh ideas he's bringing to the table. But again, on behalf of Karen and everyone who is bereaved by suicide, I want them to know that the Parliament is listening, and we know that these deaths are preventable if we have the right action and resources.
Thank you very much. Petition number 2017 is to extend the period that specialist perinatal mental health support is made available beyond 1 year, lodged by Margaret Reid. And it called on the Parliament to urge the Government to amend Section 24 of the Mental Health Care and Treatment Scotland Act 2003 to extend maternal health support beyond 1 year, to introduce a family liaison function at mental health units across all health boards, to introduce specialised perinatal community teams that meet Perinatal Quality Network Standard Type 1 across all health boards, and to establish a mother and baby unit in the north east of Scotland. The then Minister for Social Care, Mental Wellbeing and Sport, Mary Todd, wrote to the committee in February. The submission outlined work underway to produce a draft service specification for clinical perinatal services, and stated that the draft specification should be published this year. The then Minister also set out the allocation of funding to support the most severely ill women in the perinatal period closer to home in the north of Scotland. And I wonder if Douglas Lumsden, there's anything you'd like to say to the committee at this stage in relation to our consideration of this petition.
Yes, thanks, Convener. I'm becoming a bit of a regular appearing here. As you said, the driving force behind this petition, Margaret Reid, was forced to act after watching her sister struggle with postpartum psychosis 6 years ago. And because of a senseless, arbitrary time limit, her baby was older than 1. She couldn't go to one of Scotland's 2 mother and baby units in Livingston and Glasgow. She was sent to a mixed-sex mental health ward. This was traumatic, as you would expect. Now, Kate Forbes has spoken about her experience with postpartum depression after she became a mum in 2022. And she agreed to meet the Reid family in Dundee with Mental Health Minister Mary Todd to see the hell that this woman had gone through for herself. And in a written submission to this committee on June 2024, the Minister for Mental Wellbeing, Tom Arthur, wrote, "I remain committed to ensuring equitable, coordinated access to mental health provision for women, infants and their families throughout pregnancy and during the postnatal period, and appreciate the committee's interest." But since then, Convener, there has been nothing. Nothing has been done to address the fact that access to specialist perinatal mental health support is limited to the first year following the birth of a child. That is despite the Health, Social Care and Sport Committee inquiry recommending access should not be restricted in this way, and that was 4 years ago. Now, Mary Todd was also asked about the other parts of this petition, establishing a mother and baby unit in the north east of Scotland following a 2022 consultation on the options to achieve parity outside the Central Belt. And I would dearly love to see one in Aberdeen or in Dundee. And the Minister said the Scottish Government was considering its response. Now, 3 years have passed since then. Now, postnatal depression affects 1 in 10 women within a year of giving birth, according to the NHS, and suicide is a leading cause of maternal death during the year after birth. But this is not limited to 1 year after birth. Committee, this petition merely holds the SNP Government to account for what it has promised, to ensure that the same equitable, coordinated access Mr Arthur wrote about. Now, I would appreciate members' continuing consideration of this petition and to ask Mary Todd to appear and provide evidence on just what the Scottish Government have done to address the valid concerns raised within by experts and by its own MSPs. Thank you, Convener.
Thank you, Mr Lumsden. Petition number 2070 to stop same-day-only GP appointment systems was lodged by Lorraine Russell. It calls on the Scottish Parliament to urge the Scottish Government to stop GP surgeries from only allowing same-day appointment bookings, enabling patients also to make appointments for future dates. Now, in written evidence on same-day GP appointments, the Cabinet Secretary of Health and Social Care highlighted that how services are provided is left to the judgment of the responsible clinicians, and that practices are not required by the Scottish Government to provide a particular type of service. And as I set out in my opening remarks, we are now limited in the time remaining in this parliamentary session. That's just the blunt reality. And we must focus on our efforts on issues where we can make further progress. And really, by that rather hard and unfortunate criteria, I wonder if colleagues have any suggestions as to how we proceed in respect of the petitions I've just outlined and we've heard spoken to by our colleagues. David Torrance.
Thank you, Convener. Firstly, could I thank all petitioners who, the 4 petitions in front of us, have been heard by Cabinet Secretary, and some have been more successful than others, but due to the time the committee has. I wonder if the committee would consider closing petitions under Rule 15.7 of Standard Orders on the basis that the committee has progressed issues raised on individual petitions as far as possible in this parliamentary session, raised relevant issues as part of a thematic evidence session with the Cabinet Secretary for Health and Social Care.
And I think we do that on the basis that we're not exercising any judgment. I mean, we think these petitions are all hugely important and we've done what we can to progress them. But it would also be possible, of course, for a fresh petition to be raised at the start of the next session of Parliament. Fergus Ewing?
Yes, I concur with what you've said, Convener. I mean, there really is no choice. We don't have any more time left. And that's the reality of it. And, you know, we are all, I hope, pragmatists and realists. But there is the next session of Parliament, there is hope. And I just wanted to say a couple of things. Firstly, hugely grateful to the petitioners for raising these vitally important, sensitive cases, often affecting people's lives, often where petitioners have suffered loss of life in their family. And I think it was right to record that and reflect on that. And secondly, I think in every case these petitions have cast the light of open public debate in this committee on each of the issues, and we have not hesitated to exert maximum pressure on ministers at every opportunity. And lastly, I have to say, and I don't mean to be political or negative, but I have found the response from the Scottish Government to be less than satisfactory on all of these petitions, I'm afraid. We must do better in Scotland. We have to do better, otherwise we're simply letting people down. And if this committee serves any purpose, it's to speak up for people who come to this committee as best we can. And I hope that these issues will reappear, as I'm sure they will, in the next session of Parliament. I hope with a government that's willing to listen more to the people it's supposed to represent.
Thank you, Mr Ewing. I mean, although I would recognise that in the essential tremor treatment in Scotland petition, the aims of the petition in that case have actually been achieved, which is good to hear, because I remember our consideration of this at the earlier stage in the Parliament when people still were being sent to England, and it is good to know that we now have a centre here in Scotland. Are the committee minded to support Mr Torrance's proposal? Yep, we are, thank you. We move then to petition number 1911, the Review of Human Tissue Scotland Act 2006 as it relates to post-mortems. One of the long-standing petitions we have consideration to in this Parliament, lodged by Anne Stark, who, if my glasses aren't fogged over and I can see into the distances, with us in the gallery this morning. And it calls on the Scottish Parliament to urge the Scottish Government to review the Human Tissue Scotland Act of 2006 and relevant guidance to ensure that all post-mortems can only be carried out with permission of the next of kin, do not routinely remove brains, and offer tissues and samples to the next of kin as a matter of course. I notice Monica Lennon is with us again in relation to this consideration, which we last considered on the 23rd of April when we agreed to write to the Lord Advocate. Throughout the lifetime of the petition, this committee has considered a number of issues concerning bereavement and pathology services, and we've heard about specific improvements that could be made, such as the use of CT scanners for modern post-mortems and giving loved ones more choice on the return of tissue samples. Indeed, we had a fascinating evidence session with clinicians who are using scanners for post-mortems elsewhere in the United Kingdom. We took evidence from the Lord Advocate and practitioners in England, and the committee also raised several of Anne Stark's points in writing with the Scottish Government, the Lord Advocate, the Royal College of Pathology. That work uncovered that there has been a lack of ministerial leadership to oversee and drive forward improvements in pathology services. And I put this issue to the First Minister directly at the Conveners Group, and the First Minister followed up that subsequently in writing. The Scottish Government has reiterated on a number of occasions its position that it is essential that the Crown Office and Procurator Fiscal Service are able to undertake independent investigations into the cause of death where a death is sudden or unexplained. The Scottish Government also maintains that it does not support legislative change to offer tissue samples to next of kin as a matter of course. On the wider issues we've explored, the Lord Advocate has provided information about the Crown Office and Procurator Fiscal Service's exploration of CT scanning. Senior representatives visited Dr Aidley, the senior coroner from whom we took evidence back in May 2023, along with pathologists and radiologists in Lanarkshire. The Lord Advocate stated that the information obtained was very helpful and will form part of the ongoing discussions about any improvements that can be made to the process of death investigation. However, the Lord Advocate stated that it is clear that the use of CT scanning is only one tool that can be available to assist in establishing a cause of death, and it cannot replace the need for an invasive post-mortem examination in every case. And I think the committee accepted that was obviously true. In certain circumstances, a post-mortem will always be an invasive post-mortem will be necessary. However, the submission highlights that CT scanning is available in some circumstances in Scotland, although this has been restricted to particular cases such as homicides. From May this year, Glasgow University Pathology and NHS Greater Glasgow and Clyde Health Board were due to begin a service development pilot to investigate the potential benefits of incorporating CT scanning in Procurator Fiscal instructed post-mortem examinations. The petitioner, Anne Stark, has provided a written submission which reiterates her view that the Crown Office and Procurator Fiscal's investigations into deaths should look only at criminal circumstances rather than all explained or sudden deaths, and she is continuing her call for non-suspicious deaths to require permission from the next of kin. The petitioner also reiterates that changes to the system would create cost savings which could be used elsewhere in the public sector. The committee has received a written submission ahead of this morning's consideration from Mark Griffin MSP, which calls for this petition to be carried over to the next parliamentary session. Monica Lennon is with us this morning, and I wonder if there's anything that Monica would like to add before we consider what best to do next.
Thank you, Convener. That was a really helpful summary of all the work that's been done, and I think we can see already the petition has shown a light on practices that most families know nothing about until they are bereaved and find themselves in this really difficult situation. So again, pay tribute to Anne, her husband Jerry, and Anne's here today with her friends. It's been a very difficult few years for the family. I know that Anne will feel that not a lot of progress has been made, but I think having the Lord Advocate here to give evidence, we were able to follow up on that. The commitment around the scanner project is welcome, but it's clear that Scotland is still out of step with the rest of the UK and Ireland, and indeed other parts of the world where families do have more choice, and where reforms have been made following scandals coming to light. Colleagues will remember that Anne and Jerry had to hunt around Scotland to reclaim samples of Richard. You know, we went to the Queen Elizabeth Hospital after being told there were no more tissue samples, and then they were found, and no one's ever truly apologised for that. Just last week, Anne advises that the Procurator Fiscal told her that the officials who attended the day that Richard died, their names have all been redacted from paperwork for data protection, but there is no transparency for families when their loved one has an invasive post-mortem, even when the death is clearly not suspicious, as was the case with Richard. So for Anne, these remain very traumatic and heavy issues. In terms of what next, I mean, I really appreciate that you have taken us directly to the First Minister convener, but we still don't have clarity on the scanner pilot, and I think it would be good to hear directly from the Lord Advocate and her team on that. And this issue about informing and getting permission from next of kin, and the real issues around human retention. It's not really an issue for the petition, but Anne has asked me to draw to your attention some of the media coverage over some very difficult issues right now around human bones being sold widely on the internet. When organs are being retained and families don't know, you can imagine where people's minds end up. And again, I refer to the part of the petition that does say that brain should not be routinely removed if it's not a suspicious death, and I think the reasons for that have been set out in other sessions. So again, I sympathise with the committee in terms of the time that the Parliament has left, but I would agree with Mark Griffin that by keeping this on the agenda, we can hopefully continue to make some progress and momentum. It's such a taboo issue. It's difficult to talk about. It's been difficult to get MSPs and ministers to kind of get involved in this. But I think at the moment, the committee is not just Anne's only hope, but the thousands of people, the 3,400 people who've now signed this petition, who are looking to the committee for your help. So thank you, Convener.
Thank you, Monica Lennon. I absolutely want to pay tribute to the petitioner, who I think's work on this has been remarkable, particularly given the circumstances that led to the raising of the petition in the first place. I think there's been progress made in the sense that we have been able to articulate issues in a way that they haven't been articulated before, and take evidence sessions in relation to all of this. And it strikes me that potentially this, depending on the decision of the committee, would absolutely be admirably pursued in a refreshed petition that actually took account of what progress had been made in this Parliament for the next Parliament's Petitions Committee to consider. But David Torrance, have you any formal proposals put before us this morning?
Thank you, Convener. And can I thank Anne for the work that she's done on this, because I know the continuous emails that she has sent me, I've read them, keep me updated and the committee members updated throughout the whole process that we've been through.
I think it's fair to say no petitioner has been more assiduous in keeping the members of the committee abreast of developments, some of which have been out with this committee. They've been directly as a result of her own intervention.
Yes. And I think in the whole time, myself and the convener who have been on this committee, should we say at least 13, 14 years? Yeah. I don't think I've seen a petitioner pursue her cause as fiercely and as dedicated as yourself, Anne. So thank you. Can I say, I'm going to suggest that you bring a new petition in the new Parliament, because it will give it time to be seen totally. So I am suggesting that we close the petition under Rule 15.7 of Standing Orders, on the basis that the Scottish Government does not intend to amend the Human Tissue Scotland Act 2006 to require consent from families for procurative fiscal post-mortems. The Scottish Government does not support legislative change to offer tissue samples to the next kin as a matter of course, and the committee has extensively explored issues raised in the petition, including the multiple oral evidence sessions, a substantive letter to the Scottish Government, and a question directly to the First Minister.
Fergus Ewing.
Yes, I absolutely support the tributes that both you, Convener, and Mr Torrance have made very eloquently to the petitioner for her efforts. I just wanted to make a few other remarks. I think that this petition is now over 4 years old, just over 4 years old. I don't think had this petition had it not been pursued so determinedly, doggedly by the petitioner, I don't think the pilot for the scanner would ever have been granted. I also think that because that pilot began in May 25 in Glasgow, it would make sense to see what the outcome of that pilot is. I thoroughly endorse the idea of bringing back a petition, but if CT scanners can be used, then some of the anguish that was caused to the petitioner in the loss of Richard would have been well, avoided. And therefore, I think it does make sense for the petitioners to consider ascertaining, perhaps through local MSPs or MPs, more information as to how that pilot is doing, when it is concluding, when the outcome will be known, will there be any delay, as there so often sadly is, and then that might inform a further petition. I also wanted to support what Monica Lennon said. I for the life of me, can't understand why the Lord Advocate, a lady for whom I've got the utmost respect, didn't see fit to offer an apology. And the last thing I would say is that in her submission, she said that the reason why there's no change being proposed is that they cannot prejudice the need to have independent investigations. Well, that's absolutely true. Of course, the whole point of having a separate prosecution system from Parliament is that it's entirely independent of politicians. That's absolutely the core of the system of democracy. But in no way does that prevent the return of tissue or indeed the avoidance of invasive post-mortem techniques. In other words, that doesn't prejudice independent investigations. So I think that's a complete false argument, a non sequitur. It's very disappointing that the Lord Advocate should present an argument which does appear to be, I would argue, Convener, flawed. So I'm pretty sure we'll return to this in the next session, those of us who may be here then.
Thank you, Mr. Ewing. And of course, one can't predetermine who the government of Scotland will be after the next election either, or whether, in fact, the complexion of that government might lead to a different view being taken were a fresh petition to be tabled. Are colleagues content, though, to pursue, however reluctantly, Mr Torrance's recommendation? We are. So we thank the petitioner very much, and anticipate that the petitioner will ensure that these issues remain alert to the Parliament in the next session. Petition number 1962 to stop motorhomes parking overnight out with formal campsites, caravan parks and areas. And this is brought forward by Lynn and Darren Redfern. It calls on the Parliament to urge the Government to improve licensing enforcement on motorhomes, to ensure they are only parking in designated and regulated locations. We last considered this petition in April, when we agreed to write to the Scottish Government to ask whether, in the interests of safety and parity with formal campsites and areas, landowners who allow overnight motorhome habitation should be required to obtain a licence for that activity. The Scottish Government's response to the committee sets out that the Caravan Sites and Control of Development Act 1960, Schedules 1 to 6, make reference to allowing overnight motorhome caravan habitation. Under the legislation, a landowner does not require a licence if they allow 3 or less caravans at any given time to stay for a maximum of 28 days within a 12-month period. A licence would be required if more than 3 caravans were sited in the land, or if the land was in use for more than 28 days in any 12-month period. The paragraph 3 exemption only applies if the total period of occupation by caravans is less than 28 days in any 12-month period. The 28-day limit does not reset after a period of occupation by one or three caravans ends. The Scottish Government submission notes that decisions as to whether any particular use would be material in planning terms are made by the relevant planning authority on an individual case-by-case basis. The submission states that because of these existing licensing and planning rules, the Scottish Government's view is that there is no requirement to change the existing legislation. The petitioner's response to the information provided in the Scottish Government submission is that people are making up their own rules, rather than following what is set out. The submission highlights instances where sites are operating without a licence, but authorities do not seem to care about it, quote, or cases where people are operating in grey areas in which overnight stays could technically be allowed. Edward Mountain MSP has provided a written submission which states that there is no control of the use of parking sites over the 28 days set out in the legislation. And Mr Mountain's submission states that in fact parking sites are actually available 365 days a year. Do members have any suggestions or comments for action? Mr Torrens.
Thank you, Convener. In light of evidence from the Scottish Government, I wonder if the committee would consider closing the petition under Rule 15.7 of Standard Orders on the basis that the Scottish Government is of the view that there is no requirement to change the existing legislation, and the committee has no time remaining to progress the issues raised in the petition. In saying that, if a petitioner might consider bringing a fresh petition in the new parliamentary session.
Thank you, Mr Torrens. I mean, we obviously have evidence from parliamentary colleagues directly challenging the assertion in relation to the implementation of the existing law, which contradicts the government's reliance on the fact that the law exists if nothing's being done to enforce it. So, again, I think this is a petition which still has merit and opportunity for further consideration, but are colleagues content, given the reasons Mr Torrens has outlined, with the suggestion that he has made? We are. Thank you. Petition number 1976 to backdate council tax discounts for dementia to the date of GP certification. This petition was lodged by Derek James Brown, calls on the Parliament to urge the Government to require council tax discounts to be backdated to the date a person was certified as being severely mentally impaired, where they then go on to qualify for a relevant benefit. And we last considered this in March when we agreed to write to the Cabinet Secretary for Finance and Local Government, because I think we were quite struck again by the merits of the petition as raised. The Cabinet Secretary for Finance and Local Government's response to the committee states that the Scottish Government appreciates the concerns that have been raised by the committee and it agrees in principle with the argument presented by the petitioner. The submission confirms that the Scottish Government is actively exploring now legislative options and intends to bring forward proposals in the coming months to address the issue in the petition. Well, the petitioner has warmly welcomed the Cabinet Secretary's response and hopes and trusts that the Scottish Government's work will lead to the adoption of the request put forward in the petition. So in this instance, an encouraging response from the Government. Hopefully, the aims of this petition can be fulfilled. And in the circumstances that we've been returning to all morning, I wonder, Mr Torrens, if you have a proposal for the committee to consider.
In light of evidence from the Scottish Government, which is very positive, I wonder if the committee would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government is actively exploring legislative options and intends to bring forward proposals in the coming months to address the issue in the petition.
Are we content with Mr Ewing?
Yes, I've noticed the exact wording that the Cabinet Secretary for Finance uses in the written submission of 5th of November, which is, I can confirm the Scottish Government is actively exploring legislative options and intends to bring forward proposals in the coming months to address this issue. I mean, without being pedantic here, it doesn't necessarily mean that the Cabinet Secretary is going to do what the petitioner asked. So I'm not suggesting that we keep the petition open. I think we have achieved with the petitioner's stimulus the outcome that the petitioner appears to have set out to achieve. But I wonder if we might, in closing the petition, simply write to the Cabinet Secretary and urge that she make it clear to Parliament as soon as possible precisely what is going to be done, and at the same time, as a matter of courtesy, copy her letter to the petitioner.
I'm quite happy with that additional suggestion. Mr Ewing, colleagues content with that? And I think Mr Ewing is also suggesting that parliamentary colleagues might want to keep a wary eye on any such announcement of proposals in the time that remains before Parliament, because obviously all colleagues will have an opportunity to raise these matters in Parliament. But we're therefore content to proceed as was suggested by Mr Torrance with Mr Ewing's addendum. We are. That brings us to petition number 2130 to make it illegal to remove all the hair from a horse's tail, lodged by James A. Mackey, and it calls on the Parliament to urge the Scottish Government to introduce a ban on the removal of all hair for a horse's tail to leave a bare stump other than for medical reasons. We last considered this in March. We agreed to write to the Government in order to seek further information on the work to update the Code of Practice for the welfare of equidae, including timescales for completing this update, and how the petitioner and other stakeholders might contribute to the process. In the response sent to the committee in April, the Scottish Government stated that its new equine code was being drafted by stakeholders and that it was confident there was, quote, a sufficiently wide-ranging and varied base of equine expertise already contributing to it. The Government anticipated publication of the code by the late summer. However, there has in fact been no evidence that this has happened. In addition, those submissions, both the petitioner and the Animal Concern Charity suggest that a number of organisations are supportive of a ban, and they also point to the decision taken by Great Yorkshire Show to ban all horses with shaved tails from any competition or exhibition. Do members have any comments or suggestions for action? In this instance, I do think, since we were promised something by the end of the summer and it hasn't been published, that it might be appropriate for us to keep this petition open a little bit longer and to write to the Minister for Agriculture and Connectivity and ask for a progress report and a rather more clear timeline for the publication of the Scottish Government's Equine Code, since it was promised and hasn't yet happened. Mr Ewing?
Yes, I agree with that, and in doing so, I wonder if we could ask the Government to respond to the petitioners and Animal Concerns submissions of the 30th of October and 5th November. I think it was the petitioner who pointed out that perhaps we should have written to the Scottish Society for Prevention of Cruelty to Animals. I think he's probably right. So, mea culpa, or is it nostra culpa? But our fault. I just thought I should put that in the record because I'm grateful to the petitioner for pointing that out. But now we've got the petition, we've got the response from Animal Concern. There's quite a lot in it, and I think it would be helpful to put that to the Minister. Although the main point is the code was promised in summer and hasn't yet materialised.
Thank you, Mr Ewing. I think it's clear, due to your erudition, that Latin is frequently found in common usage in this committee, more than any other committee of the Parliament, but we will move forward in any event, mea culpa or nostra culpa, whatever. We'll keep this petition open, I think, and we will pursue the issues just as described. Correct? Are we content? We are. Petition number 2132 to publish a timeline for the duelling of the A96 between Inverness and Nairn by Easter 25. This petition was lodged by the Inverness Courier, called on the Parliament to urge the Scottish Government to publish a clear timeline for duelling of the A96 between Inverness and Nairn, and the construction of a bypass for Nairn, ensuring that this timeline is made public by Easter 25. We last considered this after Easter 25, when we wrote to the Cabinet Secretary for Transport. The response informs us that Scottish ministers took title of the land acquired through the General Vesting Declaration, GVD process, on the 21st of April. On the matter of a timetable for progress, the Cabinet Secretary states that this would be set in line with available budgets following completion of the work to determine the most suitable procurement option for delivering the schemes. The Cabinet Secretary indicates that this work would align with the work to assess the mutual investment model, the MIM, for the duelling of the A9. Therefore, the decision on the use of the MIM for the A96 would be considered alongside or following the A9 decision, which the Cabinet Secretary expected for, and I quote, later in 2025. There have since been no further updates publicly regarding this work. Well, do comments have any suggestions as to how we might act? Mr Torrance.
Thank you, Convener. I wonder, in light of the evidence and the delays in implementation, I wonder if we could consider writing to Cabinet Secretary for Transport to ask for updates regarding the Scottish Government's assessment of the most suitable options for the procuring and construction of the A9 dual Inverness to Nairn, including the Nairn bypass scheme. To ask the Scottish Government's assessment of the mutual investment model for the A96, which was due to be considered this year, alongside the Mint assessment for the dualling of A9, and the Scottish Government's progress on development, a detailed timeline for the project asked in the petition.
Okay, does that cover that? Mr Ewing?
Yes, I'm grateful to Mr Torrance for making those suggestions with which I heartily concur. I'd just like to say, obviously, I have a strong constituency interest and have had for 26 years. And the Nairn bypass was promised to have been delivered as part of the dual A96 by 2030. That ain't going to happen. And Nairn is probably, in the summer, about as congested as any town in Scotland, because there's really only one way in and one way out for most traffic. Increasingly, there's rat runs which are used to smaller roads, which are causing huge concern, and roads traffic incidents. They're being used to cut out the delay of using the A96 going through Nairn, which is can take up to an hour. So this is really a very serious matter. The Inverness Courier held a public meeting at which the Transport Secretary attended, to be fair to her, but she wasn't able to answer the question of the timeline nor the financing, despite the fact that the Scottish Government's budget is now £7,000 million a year. So, you know, over the next few years, there's more than enough money to deliver on the promises that have sadly been broken. Just last thing I would say is that on the A96 as a whole, the dualling programme, including this section of it from Smithton to Aldern, there's no less than £92 million has been spent, but not an inch of tarmac has been laid. How that can possibly have been achieved is something completely beyond me and my constituents. But I do hope that in writing to the Minister, we could also ask when she will make a statement to Parliament, which has been promised, and will that be this year, or will it be at the very fag end of this Parliament, as indeed was the announcement about a section of the A9 dualling made in February or March 2021, a section which hasn't actually yet been dualled, incidentally. So this has been a tale of woe, and you know, I don't wish to take up the committee's time, but it's a highly important matter for the people of Nairn and the Highlands. Thank you.
I think that's understood, but you are agreeing with Mr Torrance's proposal?
Yes, I do, yes.
Are colleagues content? Here we are. It brings us to petition number 2135 to implement the International Covenant on Civil and Political Rights, the ICCPR, in Scottish legislation. This was lodged by Henry Black Ferguson on behalf of We Collect Scotland. And as we consider this petition, it would be appropriate to acknowledge the recent passing of the petitioner, Henry Black Ferguson. The committee is aware that Mr Ferguson was dedicated to this particular cause and understands that his campaigning work will continue through his colleagues and friends at Respect Scottish Sovereignty. And we're grateful to Mr Ferguson for the time he took in pursuing this petition to the Scottish Parliament on a matter that was of great importance to him. Indeed, he wrote to the committee just not that very long ago. The petition calls on the Scottish Parliament to urge the Scottish Government to ensure that prior to the next Holyrood parliamentary election, the International Covenant on Civil and Political Rights, the ICCPR, is given full legal effect in the devolved lawmaking process. Now, we last considered this petition on the 2nd of April, when we agreed to write to the Cabinet Secretary for the Constitution, External Affairs and Culture. Members will recall that the National Task Force on Human Rights Leadership considered whether existing treaties should be incorporated into Scots law through the Scottish Government's new Human Rights Bill, and did not recommend the incorporation of the ICCPR. Now, Cabinet Secretary's response to the committee reiterates that the Scottish Parliament can only give effect to the provisions of international treaties within its powers and responsibilities. This means that the incorporation of the ICCPR would not extend the Parliament's powers, nor allow the Parliament or the Scottish Government to do anything that would have previously been beyond devolved competence. The Cabinet Secretary also notes that the majority of the rights in the Covenant have already been given domestic legal effect through the Human Rights Act of 1998. The petitioner provided 2 written submissions to the committee. The first of those sets out information that he felt should have been included in the introductory remarks when we last considered the petition. And the second written submission states the petitioner's view that because there was no notion of devolved competence prior to the Scotland Act, any argument that implementation of the Covenant might be beyond devolved competence is meaningless. The evidence states that as the UK ratified the Covenant in 1976 and devolved its implementation through the Scotland Act, the next step is implementation by a majority of MSPs. Notwithstanding the argument put forward in the petition, the evidence we have received from the Cabinet Secretary and Scottish Government, as well as the information set out in the SPICE briefing, have been clear on this issue. While the Scottish Parliament does have the power to legislate to implement international agreements such as this covenant, this does not extend the powers of the Parliament to allow it to take action that is beyond devolved competence. The committee has also received a written submission from an individual, Ewan Kennedy, which expresses his view that the covenant is a long-established cornerstone of the principles necessary to support modern democracies. In the light of the very firm direction from the Scottish Government, supported by the independent research body within the Parliament, do colleagues have any suggestions as to how we might proceed? Mr Torrance?
Thank you, Convener. In light of the direction that we've been given from SPICE and the Scottish Government, I would ask the committee to consider closing the petition under Rule 15.7 of Standard Orders on the basis that the Scottish Government is committed to a new human rights bill that will incorporate further international human rights standards into Scots law. The National Task Force on Human Rights leadership did not recommend incorporation of the International Covenant on Civil and Political Rights into a new human rights bill. And while observations and implementation of international obligations are not specifically reserved under the Scotland Act, this only applies to devolved matters within the competence of the Scottish Parliament. This route cannot be used to effectively extend the Parliament's powers by claiming that the incorporated international treaty provision now allow the Parliament or the Scottish Government to do anything that would have previously been beyond devolved competence.
Mr Ewing.
Yes, thank you, Convener. I was pleased that you made reference to the fact that sadly we've Henry Black Ferguson, the petitioner, has passed away, and I think it's fitting that just say a few additional words. That Mr Ferguson was an accountant who went to work in the Bahamas and was the CFO of an airline company, but he never lost his love for Scotland, and his commitment to the cause of independence for Scotland was absolute. He was the co-convener of Respect Scottish Sovereignty, and has pursued this petition along with many others, some of whom are in touch with me, Convener, I should acknowledge, doggedly, attracting 7,500 signatures, which is a significant number. At heart, this petition is about the principle set out in Article 1, as Ewan Kennedy states, and in his submission, from which he quotes that all peoples have the right of self-determination. By virtue of that right, they freely determine their political status and freely pursue their economic, social and cultural development. That principle is one that I hope we would all support and endorse in its entirety. However, the implementation of it in Scots law has become ensnared. A matter of principle has become ensnared in an issue of entire technicality, namely interpretation of the Scotland Act. Now, I'm no expert, but I understand the argument that the Scotland Act and Section 30 of the Scotland Act allows matters to be devolved, but that in turn requires the permission of the UK government, which is the superior parliament in their devolution arrangement. So that, in short, is where we stand. This is an argument that a cause that will never die, will continue until it is successfully achieved. And I pay tribute to Mr Ferguson and all the petitioners, but we are not plainly going to get any further in this Parliament. And whilst we may have a dream, we are also pragmatists, and that dream will not be achieved in the immediate future. But thanks to Mr Ferguson and others whose dogged pursuit of this cause we shall prevail one day, if I may be permitted to make that assertion, Convener.
Thank you, Mr Ewing. Notwithstanding which, our colleagues content that we proceed.
Agreed.
Thank you. So we do. So I've just had a note to say that the Westminster Government's budget has been completely leaked ahead of it being delivered this afternoon. Petition number 2146 to allow the use of privately sourced donor eggs in NHS-funded IVF treatment. I'll come round to it. I've just got the wrong around. This is lodged by Jamie Connolly, and it calls on the Parliament to urge the Scottish Government to allow couples and individuals to purchase altruistically donated eggs from private clinics for use in NHS-funded IVF treatment, to instruct NHS Scotland to create a clear clinical pathway to support those using private donor eggs. We last considered this petition on the 23rd of April when we agreed to write to the Scottish Government. The Scottish Government's response states that NHS boards collect data in regard to the waiting times for couples requiring an altruistic egg donor. The fertility centre with the longest wait time is currently Glasgow Fertility Centre, which advised the Scottish Government that couples who require an altruistic egg donor may wait between 3 to 4 years for treatment. All of the waits at the other 3 fertility centres are below this time. The Scottish Government therefore believes that as far as possible NHS fertility centres are meeting the needs of couples who require donor gametes, including donor eggs and their NHS fertility treatment. The petitioner's written submission to the committee questions, in light of the Government's assertion on this issue, why patients are being advised then that their potential wait for time for eggs is likely to exceed 30 years. He states that there are people and couples who are removing themselves from the assisted conception process due to the information they are being given regarding potential wait times for eggs. Do members have any comments or suggestions for action? I feel Mr Torrance is bursting with...
Thank you, Convener. I wonder, in light of evidence from the Scottish Government, if we consider closing the petition under Rule 15.7 of Standard Orders on the basis that the Scottish Government position is that couples who are eligible for NHS fertility treatment should not pay for any aspect of their treatment, including the purchase and use of donor gametes. And for NHS-assisted conception units, run local donor gamete campaigns within the NHS Greater Glasgow and Clyde, planning several campaigns this year to recruit egg and sperm donors to reduce waiting times.
Thank you, Mr Torrance. Are colleagues content? We are. The final continued petition for consideration today is 2140 to introduce a parking badge for pregnant women, lodged by James Bruce. This calls on the Scottish Parliament to urge the Scottish Government to introduce a new parking badge to assist women being able to get in and out of their cars while they're pregnant and for the initial months after their pregnancy. We last considered this in April. We agreed to write to the Scottish Retail Consortium, and their response states that most stores located in high streets or in retail parks do not have customer parking of their own. Instead, this is often provided by other local authorities, privately operated car parks or the retail park landlord. I'll remind members that in the initial response to the petition, Transport Scotland stated that there were no plans to create separate concessionary badges, nor to widen the automatic eligibility criteria for the Blue Badge scheme, which has been designed for disabled people. The Government has also informed us that decisions to offer alternative parking concessions for off-street car parks sit either with the relevant authority or landowners. So I think we pursued the Scottish Retail Consortium as a last resort, but I wonder if colleagues have any suggestions for action. Mr Torrance.
Thank you, Convener. I wonder, in light of evidence, if the committee would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government considers the ask of a petition not to be practical and achievable in part only. Makes clear that the Scottish Ministers are not responsible for reviewing guidelines or procedures, considers that amending the 2007 regulations is not a practical solution to addressing wait times, and introducing case progress and hearing timelines in primary or secondary legislation would require consultation and comes with a cost and resource implications. Points to the steps that have been taken in conjunction with SCTS to address the underlying practical reasons for wait times, including the reluctant appointment of additional members of the First Tier Tribunal. And I am reading And I apologise because I have got my papers mixed up. So I would ignore exactly what I says, convener, okay?
Well, I was slightly confused, I have to say. Well, interesting as those recommendations were, Mr Turns, I did think they strayed a little bit from the asks of the petition. But I wonder, in the light of that, whether you have you a recommendation that would directly speak to the petition itself?
I think that was because the convener jumped the petition there.
I do apologise. How dare I keep everybody alert?
Sorry. Thank you, Convener. In light of evidence, I wonder if we could consider closing the petition under Rule 15.7 of Standards on us on the basis that the Scottish Government has no plans to create a separate concessionary badge or to widen the automatic eligibility criteria for the Blue Badge. The Blue Badge scheme is designed to support disabled people who experience several barriers in their mobility and only applies to on-street parking. The decision to offer parking concessions at other types of facilities is a matter for relevant authorities and landowners.
Thank you, Mr Torrance. Do colleagues agree? I mean, I think we were on a bit of a last resort pass by writing to the Retail Consortium, given the previous advice we'd received, but we thought it worth a punt, but I don't think it's really taken, unfortunately, the aims of the petition any further forward. So are we content to support Mr Torrance's recommendation? We are. Brings us to agenda item 3, which is the consideration of new petitions. And I should highlight, as I always do, that before we consider a new petition, we initially seek the view of the Scottish Government, and we also receive a briefing from the impartial research service that is provided here in the Parliament by SPICE. And we do that because historically these were the first two things we thought we would do to pursue a petition. And so we shortcut that process by so doing. At the risk of colleagues having to keep up, given that Mr MacArthur is with us and his petition was a little bit later to be considered, I'm going to bring it forward and consider it first in the expectation that he will have productive hours to spend on other matters in the Parliament. So we will start with petition number 2188 to extend the National Entitlement Card scheme to include ferry travel for people aged 60 and over. This has been lodged by Claire Sparrow, and it calls on the Parliament to urge the Government to extend the National Entitlement Card scheme to include ferry travel for people aged 60 and over. The Scottish Government's response to the petition highlights the publication of the Islands Connectivity Plan Strategy approach in May this year, and the expanded concessionary ferry travel for under 22s only. The response states the Scottish Government does not consider the ask of the petition to be achievable, as it's not affordable to expand ferry concessions any further to include over 60s at this time beyond what is already provided. The petitioner has provided 2 written submissions which highlights that ferry travel is essential for older adults living on islands. They sometimes have to attend healthcare appointments not available locally. I can think of islands even in the west of Scotland where that is the case, to purchase groceries and other necessities, to maintain social and family connections. The petitioner states that older island residents are effectively excluded from the same freedom of movement that their mainland counterparts enjoy, and she points out that the current arrangement means that before island residents can reach a bus service where free bus entitlement applies, they must first pay for ferry travel. The petitioner states that this is not simply a matter of inconvenience, it's a matter of geographical inequality and social isolation. And I wonder, before we consider whether there is in fact anything that the committee can do in the time available to us, if Mr MacArthur would like just to offer a few comments.
I'm very grateful, Convener, not least you upending your agenda for these petitions to accommodate me. But I mean, I would certainly echo the sentiments of the petitioner. I'm not sure I'm betraying confidence. He suggests she's a resident of an island that doesn't have either a GP or a nurse on the island. There is no shop. And accessing services is very often only achievable having taken the ferry onto the mainland. I have long made the argument that for islanders in Orkney, and I think it's the same in Shetland and Western Isles and on the West Coast, ferries very often perform the function that buses perform on the rest of the mainland. And therefore, I think the extension of concessionary travel on buses for younger people as well as for older people, while very welcome, I think has led to a growing kind of inconsistency with the way in which islanders feel that they are treated. I think the government are right and to be commended for the extending of the entitlement to those under 22. That was a case I strongly made along with other colleagues for the Highlands and Islands across parties. I think the problem for the government is, having accepted the principle in relation to under 22s, it becomes more difficult to sustain the principle that you can't do it then for those over 60. So I'm supportive very much of the principle and the argumentation behind this petition. In the time available between now and the end of the session, I'm I say, pragmatic enough to understand that it may be difficult to make progress, but I think it's an argument that's not going to go away. And as I say, as a result of the more recent decision in relation to under 22s, I think the government has helped make the case that Claire Sparrow and other signatories of this petition, I think, are quite fairly making.
Thank you very much, Mr. MacArthur. I mean, there's an issue here. Mr. Torrance.
Thank you, Convener. I'm back on track. I wonder if the committee would consider writing to the Cabinet Secretary for Transport to ask her to respond to petitioners' points that ferry travel is essential for older island residents to attend healthcare appointments and maintain social connections, and that older island residents are being excluded from the same freedoms of movement as their mainland counterparts have.
That's a powerful point. I think a perfectly reasonable one for us to make an inquiry in respect of. So we'll keep this petition open and hope that we can get a response that would allow us to at least consider the Cabinet Secretary's response to that point. Yes, we are agreed. Thank you, Mr. MacArthur.
Shortly.
Yeah. Indeed. Petition number 2187 to reinstate 6 monthly dental check-ups for state pensioners. This has been lodged by David Corner and calls on the Parliament to urge the Government to reinstate the 6 monthly check-up dental check-up for state pensioners. The Spice briefing explains that in November 23, substantial reforms were made to the treatments provided by dentists offering NHS care. Prior to these reforms, patients would be sent a reminder to visit their dentist on an annual basis, although a number of dentists did this once every 6 months. The reform introduced the extensive clinical examination, which is intended to be more thorough and for which most people will be recalled annually rather than within a shorter interval. However, dentists can still use their discretion to determine whether a patient should additionally attend a review exam between these thorough annual examinations. In its response, the Scottish Government explains that the extensive clinical examination is based on clinical guidance around the appropriate recall for dental check-ups, produced by the National Institute for Health and Care Excellence, NICE. The response confirms that dentists can still see patients more frequently than 12 months based on their assessment of patients' individual oral health needs. And the Government, therefore, concludes that the issues raised in this petition do not require remedial action. Are colleagues content? Mr. Torrance.
Thank you, Convener. In light of evidence from the Government, I wonder if we would consider closing the petition under Rule 15.7 of Standing Orders on the basis that the Scottish Government's position is that extensive clinical examination introduced by NHS dental payment reform in 2023 is based on the best clinical practice guidelines, and dentists can use their clinical discretion to see patients more frequently than 12 months based on patient risk factor.
Okay, that's Mr. Torrance's recommendation. Are we content? We are. Petition number 2180 to review the procedures and case progress timelines for the First-Tier Tribunal for Scotland. And this has been lodged by David Sinclair Ayton. The petition calls on the Parliament to urge the Scottish Government to urgently review the correct guidelines for the First-Tier Tribunal Scotland Housing and Property Chamber and introduce case progress and hearing timelines, as the protracted and timeless nature of the current process is contrary to Article 6 of the European Convention on Human Rights. The Scottish Government states that Scottish ministers are not responsible for reviewing guidelines and that the administration of the First-Tier Tribunal Scotland is a matter for the Scottish Courts and Tribunal Service. The Scottish Government does not consider possible legislative changes to reduce wait times to be a practical solution, and refers to engagement with SCTS on this issue, including the recent appointment of additional members to the tribunal and ongoing work to identify further recruitment priorities. The Spice briefing explains that procedures at the tribunal are set out in the first-tier tribunal for Scotland Housing and Property Chamber, Procedure Regulations 2017 as amended. The rules do not prescribe time periods for an eviction order application to be listed for either an initial case management discussion or hearing. The briefing refers to an answer to one of my own parliamentary questions, which states that the average timescale for an application to be heard is slightly more than 6 months. The briefing also highlights information from the Scottish Tribunal's annual report 2023-24, with the total number of applications received for 23-24 at their highest ever volume and 10% higher than 22-23. In his submission, the petitioner considers that long wait times are not solely attributable to increasing caseloads. The petitioner also argues that the proposed review of guidelines is fully achievable and suggests newer amended rules to enable expedited hearings and to introduce a provision for decisions on the granting of eviction orders without the need for a hearing when the facts of the case are not disputed by the parties involved. Do members have any comments or suggestions for action? Mr Ewing.
I think we've little alternative for the reasons we've discussed before with regard to the limited time available in this session. But to close the petition, but also on the basis that the Scottish Government has indicated that it does consider the ask of the petition to be not practical and achievable in part only, it makes clear that ministers are not responsible for reviewing the guidelines of procedures, and considers that amending the 2017 regulations is not a practical solution to addressing wait times, and that introducing case progress and hearing timelines in primary or secondary legislation would require consultation and comes with cost and resource implications, and points to steps that have been taken in conjunction with the SCTS to address the underlying practical reasons for wait times, including the recent appointment of additional members to the first-tier tribunal. Given that that is the position of the Scottish Government, I think it's not reasonable to expect that there will be any change in that position between now and the end of the parliamentary session, and possibly the additional members to the first-tier tribunal might be expected to reduce the waiting times by there being more people to deal with cases. So that's to be welcome. But I obviously would recommend that if members agree to close this petition, the petitioner may wish to see how these changes impact, whether favourably or not, and think about bringing back the petition in the next session of Parliament, if so advised.
I think that's a perfectly reasonable suggestion, and obviously my own constituency interest led to the question that I tabled, because I think these are matters of public concern in the current situation. So, are we content with Mr Torrance's proposal, but look to recommend that this is a petition that the aims of which might... Oh, have you made your proposal yet, Mr Torrance? Sorry, I just went straight to Mr Ewing. Mr Ewing has actually... I thought you'd indicated you wanted to add to that. So are we content with Mr Ewing's suggestion as to how we might proceed?
Content.
We are. Thank you. Petition number 2183 to make suicide awareness and prevention training mandatory for high school students. This has been lodged by Craig Payton. And it calls the Scottish Parliament urges the Scottish Government to make suicide awareness and prevention training mandatory for high school students to help remove stigmas and to empower young people to speak openly and to ensure teachers can spot the vital signs and take appropriate measures to prevent a fatality. And it notes that this training is in fact available in English schools. Now, the Spice briefing explains that the curriculum in Scotland is largely non-statutory, with the content of what is taught being a matter for teachers, schools or local authorities, and it notes that the Scottish Government has focused on reducing suicide since at least 2002, including working groups and a series of strategies, prevention and delivery plans published every few years. The Scottish Government refers to the Curriculum for Excellence as a broad national framework rather than a statutory curriculum, and health and wellbeing is one of the 8 curricular areas within that framework and is one of the 3 core areas identified as a responsibility for all, which means all staff across the school community share responsibility for its delivery. The Scottish Government points to resources available through Education Scotland to support learning in mental health, self-harm, suicide prevention and positive mental well-being. It also notes that Education Scotland is leading on development and delivery of the curriculum improvement cycle, with work already underway on this. Do members have any comments or suggestions for action? Mr Torrance.
Thank you, Convener. In light of the evidence in front of us, I wonder if the committee would consider closing the petition under Rule 15.7 of Standing Orders on the basis that there is no mandatory curriculum in Scotland. The curriculum for excellence is broad, non-statutory national framework, with the content of what is taught being largely a matter for teachers, schools and local authorities. Health and well-being is one of the 8 curricular areas within Curricula for Excellence, and in addition is one of the 3 core areas identified as responsible for all. The Scottish Government has pointed to resources available from Education Scotland to support learning in mental health, self-harm and suicide prevention, and notes that Education Scotland is currently leading on the development and delivery of a curriculum improvement cycle.
Are we content with Mr Torrance's suggestion? We are. That brings us to the final petition this morning, petition number 2185, to introduce stronger safeguards around the use of digital material in court proceedings. I can only apologise. I have to assume that the 3 remaining guests in the gallery this morning have suffered through the entire proceedings, only to find that their petition is the last of those that we are considering this morning. But I hope, notwithstanding that we can do something positively to assist. This petition has been introduced by Christopher Simpson, and it calls on the Scottish Parliament to urge the Scottish Government to amend the Criminal Procedure Scotland Act 1995 to ensure that any digital material presented in court, such as photos or screenshots, is verifiably sourced, time-stamped and able to be independently authenticated before being considered admissible unless both parties agree otherwise. Now, regarding current court procedures, the Crown Office and Procurator Fiscal Service have explained to our SPICE researchers, and I quote, that before any item attains evidential status, its provenance must be established. An item is meaningless unless its source is in some way proved. If the defence and prosecution do not agree on the provenance of an item, whether digital or not, there is a process in place which enables parties to challenge the evidence and lead their own rebuttal. The Scottish Government indicates that the gathering and presentation of evidence are matters for Police Scotland and the Crown and Procurator Fiscal Service. The Government does not consider the action called for by the petition to be necessary on account of existing safeguards, which are meant to ensure the concerns around the authenticity of any digital evidence can be raised and investigated. However, in an additional submission, the petitioner shares his own distressing experience, and he reiterates, and I quote, that individuals can be subjected to lengthy investigations and restrictions based on unverified or fabricated digital material. Since discussions about its provenance of evidence take place after a person has already been charged, the petitioner sees this as a gap in the legislation and insists that all digital evidence must be verifiably sourced, time-stamped and authenticated before it even reaches the courts. Do colleagues have any suggestions for action? Mr Torrance.
I wonder, in light of evidence, I wonder if the committee would consider writing to the Lord Advocate and the Chief Constable of Police Scotland and ask their views regarding the petition and regarding the timing concerns expressed by the petitioner in his additional submission.
Yeah. I mean, it strikes me that the timing concern is wholly legitimate. We know the opprobrium that can be attached to an individual being charged, and if this hasn't been corroborated before we even got to that process, a point in the process, that seems curious. So I think it's perfectly legitimate for us to seek to get further clarification in these matters. Mr Ewing?
Yes, I would support that, and also for the reason that whereas, in theory, these things, the specific proposal should be necessary. In practice, I think the petitioner has had an experience quite the contrary of failure to carry out a proper process according to the petitioner's narrative before us. So I think it would do no harm, particularly in the increasing importance of digital material and evidence in court, to understand what safeguards are in place to make sure that it is properly authenticated and verified so far as possible. That should indeed, as the petitioner, the main thrust of the petitioner's submission, that should indeed happen, but one does doubt whether it in fact does happen for various practical reasons, and not least because some of the people of my vintage may not really understand, to be quite honest, how digital material works. I would be surprised if some of my learned friends were necessarily expert at digital technology either. So I do think the petitioner has raised an interesting area of matters of evidence in criminal proceedings that should be pursued and clarified.
Yeah, and I think it would be well in pursuing these matters to say that we're not doing this on a purely theoretical basis, but that that the evidence before the committee suggests that it's an actual experience,
Yes.
and just to emphasise that point, Mr. Russell.
Can actually see recently how digital evidence can be manipulated with the BBC fiasco and our US president.
Indeed. Although last time I checked, President Trump hasn't lodged a petition before the Scottish Parliament in relation to the digital evidence at the BBC. But actually, I wouldn't put it past him because he seems to be quite free in doing that sort of thing. So we will keep this petition open, notwithstanding the time that's left to us in this Parliament, and hope that we can advance further information in relation to the particular points raised as a consequence of the additional submission from the petitioner. Mr. Ewing?
Just for the sake of completeness, I do recall, because I was present when President Trump, then a North East businessman in Scotland, appeared before a committee of this Parliament and stated that the turbines opposite his golf course should not go ahead. And he was asked about evidence. He said he was asked, "What is your evidence, Mr. Trump?" He replied, "I am the evidence."
Well, yeah, and that is currently how the affairs of the United States are conducted. That brings us to the end of that particular item. I hope the petitioner are content with that, taking forward of the petition on that basis. We now move into private session.